Thank you so much, Sudha Garu. I tried so hard to get them in the front rows. I was not successful at all. You did it. Thank you. Good afternoon, ladies and gentlemen. On behalf of Hybiztv, I, Sabrina, welcome you all to Hybiztv Medical Symposium 2022. It gives me immense pleasure to welcome you, our esteemed guests, doctors, and all the representatives from the healthcare industry. Today's session is going to be revolving around a few important topics in the healthcare arena. From public health to early detection, myths and relativities in cancer, heart diseases to diabetes, antibiotics and hypertension, BP, this and more will be covered in the coming few hours of session. Now, before we begin the sessions, there is another session which is equally important, which is the lighting of the lamp. Lamp signifies and symbolizes abundance, prosperity, and knowledge. The lighting of an oil lamp is regarded as a bow down to knowledge. So keeping this in mind, let us start today's session with lighting up the lamp ceremony. And to do the honors, I would like to call on stage the dignitaries. Please put your hands together while I call on stage Dr. Sanjeev Singh Yadav, Consultant Surgical Specialist. Sir, can we have you on stage? Practicing proctologist, laparoscopy and general surgery, Honorable National Secretary, IMA Academy of Medical Specialties. Welcome, sir. I would like to call on stage Dr. M. Sampath Rao, President, IMA Telangana. Sir, can we have you on stage with a huge round of applause? Come on. I'm sure the next lady who's going to join on stage, are going to give her a thunderous clap. Please put your hands together for Dr. Sudha Ramana, Director, Medical Services, Mallareddy Health City, Ex-Director, Medical Education, Telangana State. We welcome you, ma'am. I would like to even call on stage Dr. Sridhar Kasturi, HOD, Interventional Cardiologist, Kim Sunshine Heart Institute. And our host for the day, Mr. Rajagopal, founder and MD, Hybiztv. I request our dignitaries to do the honors of starting our session with the lighting of the lamp. Mr. Ramakishan is also requested to please join us on stage. Can we have Mr. Ramakishan? Thank you so much to all the dignitaries. Please, I request you all to take a seat. Yeah, of course, we can capture the moment. Thank you to our dignitaries to do the honors. And now let us begin the session which you all are eagerly waiting for. So we have our convener for this Hybiz Medical Symposium, Dr. Sanjeev Singh Yadav, the consultant surgical specialist, practicing proctologist, laparoscopy and general surgery, Honorable National Secretary, IMA Academy of Medical Specialties. He is going to convener of this session. Sir, over to you, sir.
Good afternoon, everyone. Thank you, ma'am. Honorable dignitaries, it was a nice pleasure to see you lighting the lamp. Without taking much time of yours, I would like to invite Dr. Ramkishan, who is the Deputy Drug Controller, ex-convener Scientific Service Committee and Director General Health Services, Ministry of Health and Family Welfare, to talk on the current situation of public health in India. Dr. Ramkishan, please.
Yeah. రండి ఒకసారి. హలో, కొంచెం పెద్దగా చేస్తారా? ఫస్ట్ స్లైడ్ పెద్దగా చేయండి. ఇంకా పెద్దగా రావాలి. ఇది ఒకటే స్లైడ్. హలో. On behalf of Central Drug Standard Control Organization, Ministry of Health and Family Welfare, Government of India, gives me immense pleasure to share my thoughts with respect to public health situation in India and special focus on Indian drug legislation and how we are approving the new drugs, clinical trial permission across the country. That I would like to focus, friends. Before going into my slides, I would like to thank Hybiz TV channel Managing Director Sri Rajgopal ji, co-partner Sandhya Madam, and Indian Medical Association Telangana Chapter President Dr. Sampath Rao ji, Dr. Gangadhar ji, Dr. Srikant ji, and Dr. Yadav ji, and Dr. Rangareddy, and all the eminent doctors invited for this today's important medical symposia, and all medical students, postgraduate and undergraduate students, special invitees, and ladies and gentlemen, and also personals, important representatives invited from the electronic and print media. Good afternoon to one and all. So, if you can see, probably I am first regulator because clubbing with all medical people. I am very happy, but at the same time, we are taking care of lot of important regulatory audits whenever we go for the GCP inspections for meeting good clinical practices, how the clinical trial investigators are taking care, what are the important responsibilities of ethics committee members, maybe institution ethics committee or independent ethics committee, as well as blood centers. How we have to keep good transfusion practices is also one of the important gazette notification issued by Ministry of Health and Family Welfare. That also I would like to share some important silent features with respect to the collection, testing, storage of whole human blood and blood components as per the Schedule F, Part 12B and 12C of important Drug and Cosmetic Act. Friends, if you can see, these are all important outline of my presentation. 20 minutes means already 5 minutes gone, only 18 minutes left. So I don't want to hammer. At the same time, having 50 slides covering in 20 minutes is a challenge, but definitely I'll put my efforts to stick to your timeline framed by the organizing committee, and definitely I'll take and cover all important slides. Here, I would like to give the important definition of the CDSCO and public health, and as a regulator, what is our vision? The Central Drug Standard Control Organization is the national regulatory apex body where we are taking care of the protection and promotion of public health in India. This is our vision, and mission is to safeguard and enhance the public health by assuring the safety, quality, purity, identity, strength of important pharmaceutical preparations, nothing but drugs, medical devices, in vitro diagnostics, cosmetic products. So these are all important things we are covering. And public health, friends, everyone knows because you are all from the medical fraternity. According to WHO, what is the definition of public health? According to WHO, public health refers to all the important organized measures, whether public or private, to prevent important diseases and promotion of health and prolong the life among the population as a whole. Its activities aim to provide conditions in which people can be healthy and focus on entire populations, not on individual basis or diseases. So in total, we have to take care with respect to the promotion of public health. So current size of the population, if you can see, as an date, the population of India is 141 crores 71 lakhs 73,173. Just I don't know last 2-3 hours, but this is the correct population as on date with respect to India. At the same time, globe, if you can see, friends, 7.9 billion global population. In that, we are second position, China 145 crores and USA 33. You see, having huge populated country, putting our efforts in entire drug regulatory sector, we are total 2,000 plus people. We are working in different regional offices and headquarters across the country. So limited resources, limited manpower, putting efforts, still people can have the allegation, and you know the last 2-3 days important incidents. So friends, disease burden, if you can see, what is the global data, if you can see, with respect to the communicable diseases and non-communicable diseases, at the global level, we are having 28% of the death rate with respect to related to communicable diseases. Whereas in India, we are having 30.61% of the death rate. So this is the important reference I got from the WHO, and non-communicable diseases 60% at the global level and 57.94% of the death rate in India. So this is the global reference, WHO reference I got for your important reference for PG students, for the benefit of PG students. You can see the NCDs are one of the important threat to our public health programs and public health issues. What are the top 10 public health issues we are taking care? WHO already defined in the year 2019. The important threats to the public health, that is global health, is one is air pollution and climate change, friends. Number two, NCDs, non-communicable diseases, and threat of important pandemic, influenza and COVID-19 SARS virus, and fragile and vulnerable settings such as regions affected by the drought and conflict. That is also one of the factors. And fifth one is antimicrobial resistance. Sixth one is all important high threat pathogens including Ebola. And weak primary care, that indicates a lot of factors influencing in that, maybe drugs, maybe diagnostics, in vitro diagnostic kits, medical facilities. All these are important challenges with respect to weak primary care. And also vaccine hesitancy is also one of the threat with respect to global health program, and important viruses like HIV 1 and 2 viruses, the dengue virus, and in near future chikungunya and other, we do not know how virus is mutating. So these are all important factors with respect to global health program, global health issues. Before going into, because if you want to have good health, if you want to prolong your good life, you need good medical products. So that I would like to focus as a regulator, how we are approving medical products, what type of rules we are having, what is the important law with respect to Indian drug legislation. If you can see, friends, based on the federal nature of Indian Constitution, areas of operations have been divided into central government and state government, everyone knows, but 7th schedule of Indian Constitution described very clearly with respect to union list, state list and concurrent list. So health and family welfare comes under the concurrent list of Indian Constitution. Therefore, respect to state government as well as federal government is responsible with respect to movement of all medical products. So this is the important thing I want to share with you. But the other important items like public health, hospitals, sanitization, you are all taken care by the respect to provincial governments. So Drugs and Cosmetic Act in our country, the main act enacted on 10th April 1940, where we are taking care of all important functions as a system of licensing under which all the activities involved, starting from the receipt of raw material, then manufacturing operations and control, step by step with respect to in-process quality control test, and also packing, step by step, maybe blister packing or strip packing or alu packing or bulk packing, depends upon the demand and depends upon the export activities and exporting countries' requirement. People are manufacturing in different forms, and whatever drugs are being manufactured at their facility according to current good manufacturing practices should be controlled in order to meet all important quality attributes, including key quality attributes also, friends. This is the one thing, and drugs are very, very important. Drug is in concurrent list of Indian Constitution. Therefore, it is governed by both Government of India and respect to state government under the provisions of Drugs and Cosmetic Act, rules framed in the year 1945. So we call Drugs and Cosmetic Act 1940, rules framed in the year 1945. So this is the thing, background information with respect to Indian National Regulatory Authority, that is CDSCO. This is one of the important authority for discharging functions assigned to the Government of India under the provisions of Drugs and Cosmetic Act 1940. So Government of India is committed to a robust regulatory system for ensuring quality, purity, safety, efficacy of all important medical products moving in domestic as well as international commerce to achieve the public health goal. So pharmaceutical sector is very, very important sector. Government of India identified total 25 key sectors. Out of that, pharmaceutical sector is one of the key sectors where we can take care of all important principles with respect to development of novel dosage forms and important medical products to treat important diseases or disorders with respect to clinical practices. So scientists and drug development people and manufacturers also responsible for ensuring the quality movement of drugs. So these are all important principles. As far as Indian NRA is concerned, we are also having close coordination with World Health Organization Geneva with respect to capacity building, maybe training, or maybe having some grants in order to uplift important skilled people in order to ensure the meeting of all current GMP principles, good laboratory principles at par with the USFDA and ICS countries. So we are all taking care, Ministry of Health and Family Welfare, in close coordination with the WHO country office, taking a lot of important strengthening regulatory practices at central level and state level, and to have regulatory ecosystem to respond health technologies in clinical trial rules 2019, online digital tools such as manufacturer database in Sugam portal, medical devices rules implementation, identifying all important steps for the micro, small, medium entrepreneurs to move the level of World Health Organization standards, strengthening safety monitoring, including strict pharmacovigilance, material-vigilance, hemovigilance program of India. Sugam portal is one of the portal created in CDSO as a part of e-governance with respect to uploading documents for online application to seek the approvals through this Sugam portal. Sugam means Suraksha, Gunavakta and Manakta, quality, safety and efficacy. This is the important definition devised by Health Ministry officials in the year 2014. So this is the background as far as e-governance is concerned. So 90% of the work is through e-governance only. So that proudly we can say Government of India putting efforts to have more transparency and accountability to the public as far as drug approval process is concerned. Friends, Drugs and Cosmetic Act, the main preamble is to regulate the manufacturing, sale, distribution and import of drugs, cosmetics, medical devices and all other important products. The objective is to ensure public health, public are supplied with quality products. So this is as per the section 3B. What is mean by drug? Everyone knows. Drug means any substance, any item, maybe liquid, maybe tablet, maybe injectable preparation meant for diagnosis, mitigation, prevention or cure in human beings or animal ailments, either for internal or external use, is called as a drug. So that is the as per the section 3B of the Drugs and Cosmetic Act. These are all important definitions incorporated and described in a comprehensive manner to understand the principles as far as safety and efficacy parameters are concerned. And basic philosophy is here, manufacturer is also equally responsible for quality of drugs being manufactured at their facility. Regulators and manufacturers, everyone is responsible. So people definitely blame all regulatory people and manufacturers sometimes, but jointly we have to put efforts as an alert citizen of the country, maybe at the manufacturing level or regulatory level. So we are doing all periodic monitoring with limited resources and trying to enforce all the important provisions of Drugs and Cosmetic Act to ensure the quality movement of drugs, maybe testing or manufacturing or pharmacovigilance or quality system or risk management principles. So these are all things, friends. Then Indian pharmaceutical industry, if you can see, one of the big important thing is every third child in our world gets the measles, mumps, rubella group of vaccines being manufactured in India, that too from the Serum Institute of India. So around 45% of the WHO supply of diphtheria, pertussis, tetanus group of DPT group of vaccines through Indian manufacturer side. And we are also number 3 at world level providing the important active pharmaceutical ingredient bulk drugs. And these are all just, everyone knows, but for the benefit of all PG and undergraduate students, you can note down that because what is the important potentials and drug pharma sector, what is the statistics we are having as and date. So to have some fingertips with respect to the data, I have prepared these slides for their benefit, sir. And highest number of USAID approved facilities in our country, and more than 2,500 pharmaceutical plants having WHO GMP approved certified facilities, and 8 out of top 20 global generic companies are from India. So these are all important strengths with respect to the Indian pharmaceutical sector. And if you see, this is the knowledge-based sector, and we are closely coordinating with all medical fraternity people. We are also having subject expert committee, that is new drug advisory committee. We are taking care of all important drug approval process, maybe gastroenterology or rhenology or cardiology or intervention radiology or medical devices, in vitro diagnostic, cosmetics, or important any item, maybe biosimilar, monoclonal antibodies, cell therapy, gene therapy. So lot of things we are taking care, and including vaccine. We are also having separate group of experts where we are evaluating with respect to common technical document for approval of all human vaccines before its distribution in international commerce. So friends, and this is the strength of our Indian pharmaceutical exports. Region-wise, North America, we are contributing 32%, and European Union 16%, Africa 18%, and South Asia 4%. So this is the data we got from the Ministry of Commerce and Industry. And total number of pharmaceutical units in our country, approximately 10,000 units, consisting of all large scale, small scale, and merchant exporters. This is the data. Total number of units engaged in exports, more than 2,209 companies are engaged with the exports. So a lot of exports people are involved in order to get revenue. At the same time, India is also putting efforts in different domains in order to focus on novel pharmaceutical products. And we are also having comprehensive legislation for approval of biosimilar guidelines, regenerative medicine, stem cells, and other important cell therapy and gene therapy products as per the ICMR guidance and as per the DBT guidelines also. So these are all important things. This is the current size of Indian industry, $48 billion market as far as India is concerned, total $1,200 billion market, and exports 24%, 24 billion, and domestic is 24. So this is the data. More than 205 countries we are having exports, and the value of production are 12th position, and we are at 3rd position with respect to volume. Lot of pharmacists across the country, more than 1 million pharmacists working across the country with respect to ensuring all important supply chain and other important pharmacies, maybe at the retail level or wholesale level. So this is the data as far as Indian pharmaceutical industry is concerned. So what is the difference between central government and state government? CDSO is the National Regulatory Authority. Our main objective is to take care of approval of new molecules, clinical trials, and in vitro diagnostic kits and medical devices also. Import registration and licensing. Recently, AAG Hospital imported some medical devices. Same day, we are clearing on fast-track basis. So through Sugam portal, earlier people used to take 2 months, 3 months. Now within a week, we are taking care Yadav Sab. So these are all the important credentials as far as national regulatory system is concerned. State government functions are wholesale, retail, manufacturing activities under perpetual licensing system. So these are all things. Drugs and Cosmetic Act objective is to ensure the important quality movement of drugs, biologicals, vaccines, cosmetics, and veterinary drugs. And what is regulated under this drugs and cosmetics? Many of the people are not aware. We are, under the Act, we are regulating manufacturing activities, distribution, import, and sale activities. So this is the important thing. Under the Act, Drugs and Cosmetic Act, we are regulating. But in case of rules, these are the important rules we have framed under the Drugs and Cosmetic rules. Clinical trials, new drugs, and exports, we are covering under the rules of Drugs and Cosmetic Act. That is the difference between the, this is the difference between the Act and the rules, friends. But new drugs and clinical trial rules based on the court cases of 2012, 33 writ petition civil number and writ petition number 79 of 2012, Indore versus Union of India, Swasthya Adhikar Manch, based on the Honorable Supreme Court of India, we are having excellent guidelines with respect to the approval of clinical trials and new drugs according to the ICH countries. That I can say, GSR 227 is the important NDCT rules with respect to the framing, the definition of the clinical trial, drug development, orphan drug, post-trial access, and important expedited review and accelerated approval, all these important parameters incorporated in the NDCT rules of 2019. In that, there are 107 rules we have framed, we have incorporated 13 chapters, 8 schedules as far as new drugs and clinical trials rules are concerned. So what is meant by a new drug? Many of the postgraduate students and undergraduate students are not aware. Earlier, this definition was as per the rule 122E of Drugs and Cosmetic Act, where the new drug definition is defined. Now the new drug definition as per the NDC rules of 2019, rule 2W defines with respect to new drug, a drug including active pharmaceutical ingredient or phytopharmaceutical which has not been used in the country to any significant extent except in accordance with the provisions of the Act and rules made under and conditions specified in the labeling thereof and has not been approved as a safe, efficacious by Central Licensing Authority with respect to its claim is called as a new drug. And what is meant by phytopharmaceutical? Phytopharmaceutical drug means a drug of purified and standardized fraction assessed qualitatively and quantitatively with defined minimum 4 bioactive or phytochemical compounds of an extract of medicinal plant or its part for internal or external use on human beings or animals for diagnosis, treatment, mitigation or prevention of any disease or disorder, but does not include drug administered through parental route is called as a phytopharmaceutical product. Very, very important, friends. And drug approved by Central Licensing Authority for certain claims and proposed to be marketed with modified or some new claims including indication or route of administration or dosage form and dosage includes also indicates new drug. And also any fixed dose combination, FDC, combination of 2 or more drugs approved separately for certain claims and proposed to be combined for first time in a fixed ratio or where the ratio of ingredients in an approved combination is proposed to be changed with certain claims including indication, route of administration, dosage and dosage form is also called as a new drug, friends. Then all modified sustained release dosage form, vaccines, RNA products and important living modified organisms, monoclonal antibodies, stem cell derived products, gene therapeutic products or xenografts intended to be used as a drug. All these are important products incorporated as per the rule 2W of NDCT rules 2019, friends. So the drugs other than the drugs referred to in a subclasses 4 and 5 shall continue to be new drugs for the period of 4 years from the date of their permission granted by the Central Licensing Authority, that is DCGI, Drugs Control General India. And subclass 4 and 5 means modified, sustained release, vaccines, RNA products, stem cells, monoclonal antibodies, always deemed to be new drugs. This is the important definition incorporated in the NDCT rules, friends. What is meant by orphan drug? Orphan drug we were not having in definition as per the US FDA and as per the ICH countries. Orphan drug definition first time incorporated in our Indian legislation, that is a drug intended to treat a condition which affects not more than 5 lakh persons or 5 lakh population in our India is nothing but a orphan drug. For that we are encouraging all scientists, those who want to carry out clinical trials, we are not charging any fees. So fees is waived off, no fees for the conduct of clinical trial in case of orphan drugs. This is also one of the important thing you can note. And provision for accelerated or expedited approval process in line of Sakigaki, PMDA Japan, how they are having the conditional approval and partial approval with respect to certain drugs, particularly orphan drugs in case of any beneficial effects to treat important life-threatening condition, we are taking care of the orphan drugs for push-up with respect to government side also, sir. And biomedical health research, we were not having any provisions in our act, but in NDCT rules of 2019, sir, there was no any regulation, but now there is a separate well-defined chapter called as Chapter 4 for regulation of biomedical health research in India. And ICMR is taking care. We are also taking care with respect to clinical trials and other important activities. Biomedical and health research means research including studies on basic research, applied research and operational research or clinical research designed primarily to increase scientific knowledge about diseases and conditions, maybe physical or socio-behavioral, their detection and cause, evolving strategies for health promotion, prevention or amelioration of disease and rehabilitation, but does not include clinical trial as defined in clause J with effective from this thing, because we have given 6 months time and effective from 19th March 2019, but with respect to enforcement of the biomedical health research, it is effective from 19th September 2019. So we have given some time with respect to understanding the BHR. BHR to be conducted in accordance with the National Ethics Guidelines for Biomedical and Health Research developed by ICMR Delhi, and Ethics Committee are responsible for biomedical health research with respect to registration process, deals with non-regulatory studies. Ethics Committee to see the overseas studies, serious adverse events, compensation dealt by Ethics Committee as per the biomedical health research guidelines framed by ICMR New Delhi only. This is very, very clear, Dr. Saab. And Ethics Committee, most of the people are not aware what exactly Ethics Committee. Ethics Committee means a committee comprising of medical, scientific, non-medical and non-scientific members whose responsibility is to ensure the protection of the rights, safety and well-being of human subjects involved in various clinical research programs, and it shall be responsible for reviewing and approving the protocol, the suitability of the investigator, facilities, methods and adequacy of information to be used for obtaining and documenting informed consent process of the study subjects and adequacy of confidentiality safeguards. So these are all important things. And academic clinical trial. So this also we have incorporated for your benefit, those who want to go for the publication. So they can do, they can take care, but they need not to get any permission from the regulatory authorities. So you can carry out academic trial means a clinical trial of drug already approved for certain claims and initiated by any investigator, academic or research institution for new indication or new route of administration or new dosage or dosage form, where the results of such trial are intended to be used only for academic or research purposes and not for seeking approval from the regulatory body of any country for marketing or commercial purpose, is nothing but a academic clinical trial. And permission from Central Licensing Authority not required, where clinical trial on approved drug is intended solely for academic research purpose for new indication or new route or new dosage or dosage form. This is very, very clear. Earlier, sir, we were having a lot of ambiguity. There is no any clarity with respect to academic clinical trial, biomedical health research, new drug and important principles involved with respect to understanding by our medicos and scientific and drug discovery people and other personalities also. So, an important thing, post-trial access also. We have given some benefit those who involved with respect to clinical trial activities. If there is any beneficial effect, if they require, then we are also having the free of cost supply of the drugs by the sponsor or as per the Ethics Committee recommendation. This is the post-trial access, means making a new drug or investigation new drug available to the trial subjects after completion of clinical trial, through which the said drug is beneficial to trial subject during clinical trial activity for such period as considered by the investigator or Ethics Committee. As per the recommendation, we can provide free of cost drug to those important trial subjects participated in that trial. And accelerator approval. So we are also having important, because if any beneficial effect with respect to clinical benefits, then we are also having fast track approval, that there is a committee will evaluate with respect to the important surrogative points. If there is any clinical benefit, based on that, we are also giving the accelerated approval. And the drugs regulated under allopathy, Ayurveda, Siddha, Unani, homeopathy, all these things everyone knows. Administration of the Act, Drugs Technically Advisory Board will take care of all technical matter. Drug controllers involved in the Drugs Consultative Committee can advise central government to take care all important regulations as far as new drugs and important clinical trial activities are concerned. Regulatory bodies, maybe licensing authority, controlling authority, or drug inspector. So laboratory, we are having Apex laboratory at Kolkata, and we are also having different state government laboratories and headed by different government analysts notified by various governments. So this is the thing. E-governance started in 2014 and medical devices rules came in 2017, and phase-wise manner we are going to implement with respect to important devices, class 1, class 2, class 3, class 4. Class 3, class 4 dealt by the CDSO, class 1 and class 2 dealt by the notified bodies and respect to state licensing authority. So this you can note down. And the last 5 minutes, madam, and because international cooperation, India, CDSO, national regulatory bodies also having MOU with all US FDA authorities, UKMHRA, PMDA Japan, Russia, Korea, KFDA, MCC South Africa, and EU, European Union. All these are international cooperation with respect to ensuring important quality movement of drugs. So as far as vaccines, Indian vaccine industry, friends, more than 21 vaccine manufacturers are located. We are having 80 vaccine manufacturers are pre-qualified by WHO Geneva. 43 vaccines in 88 formulations we are supplying to United agencies and meeting 60% of the global immunization program. So credit goes to our Indian immunobiological entrepreneurs with respect to having the more than 1250 million US market with respect to exports as per the data given by the Pharmaxil, Pharmaceutical Promotion Export Council, set up by Ministry of Commerce and Industry, Government of India. And in the year 2017, every 3 years, WHO people come with other important regulatory agencies to do the assessment at CDSO Delhi. I was there in 2017. We got 100 by 100 score with respect to clinical trial, pharmacovigilance, market registration and regulatory audits and a national policy, then market surveillance and control and clinical trials and a licensing premises with respect to all important functions. So they have developed a questionnaire called as a indicator and sub-indicators, and total 9 major functions and 63 indicators, 288 sub-indicators. Out of 280 sub-indicators, 150 points are critical in nature. Failing of any critical point is a disqualification of Indian National Regulatory Authority. So this is the update I am sharing with you, friends, with your cooperation, with the medical fraternity, with the support from all important NGOs, with the support from all the academia people. Ultimately, patient safety is very, very important. I am proudly saying today, with all the efforts from regulators, stakeholders, academicians, clinical research organization, pharmacists, Indian Medical Association President, Secretary General of India, Delhi, and Sampad Rao-ji, Yadav-ji, Rangareddy-ji, and Srikant-ji, all their efforts, Pharmacy Council of India, now National Medical Commission, earlier MCI we used to call Indian Pharma Association, IDMA, ICMR, DBT, all the agencies, judiciary, media people, scientific institution, playing greater role in achieving patient safety. So this is one of the things. As a regulator, we have to make sure that all the drugs being manufactured at the facility to meet all the important intrinsic and extrinsic factors embedded in that quality to achieve patient safety is our important objective, friend. Thank you, one and all. This is the WHO NRA Assessment 2017. Our DGHS, DG and Secretary Health. This was the photograph, and I want to share, friends, life is like a game. Juggling some 5 balls in the air. They are like work, family, health and friends. So you will soon understand that work is like a rubber ball. Study is also like a rubber ball. If you drop it, it will bounce back. But the other 4 balls like family, health, friends, spirit are made up of glass. If you drop one of this, it will be irrevocably scuffed, damaged, and naked, even shattered. They will not be never be same. You must understand, friends, and strive for it. Work efficiently during office hours, leave on time. So we have to follow the Medical Association and National Medical Commission, how they are taking care. So we are the pharmacists, they are the doctors. So how we can have the harmony for the betterment of patient safety is the important thing. Value as a value, only if it's value is value. Thank you very much, Yadav Sahab, and thank you very much to our Rajagopal ji for inviting me here to share some thoughts with respect to the current situation. of the public health and the drug regulatory sector in total. Thank you very much for giving me the opportunity. Thank you.
Thank you very much for the great input. When I was a student, I used to see behind my house one drug manufacturing unit, a small hut-like thing where medicines used to be packed and given to the public in the sense that whatever was available. But now things have changed. As medical education changed, things in the pharmaceutical industry is not the same. The drugs are manufactured with lot of care and lot of scientific research. Thank you, Mr. Ramkishan. I now invite Dr. Srinivas. Yeah, sure, Hemal, please come. Sai, join us. Randy, pike ravadu.
Yeah, Dr. Ramkishan has been very pleasant in his presentation. I would like to just put before him being the administrator of the health industry. I am also the marketing and as a drug controller, also part of the safety in the public health and see the sales are also concerned with your administration. Medical outlets, retail, medical shops, they very indiscriminately sell the drugs. Why don't you insist with your drug controllers, instruct the state bodies and in turn their network to see that that will be properly implemented. See, as you know, there are two types of drugs under the Drugs and Cosmetic Act, as you have explained, over the counter and for the prescription. Make it sure that the medical shop people will honor only the legible, qualified prescription. So this should be insisted in the interest of the public health and public safety. Please listen.
So, very good question, Dr. Saab. When I was a student, I used to get the same doubt. But I have completed 25 years in the drug regulatory sector. And now your question is going to be enlightened in our new drugs, medical devices, cosmetic bill 2022. Already draft is ready, and how to take care, how to enforce uniformly across the country with respect to ensuring quality movement of drugs, storage, distribution and prescriptions contained as per the various doctors in hospital and clinical setting with respect to issue and OTC product and prescription product. We are going to have separate chapter on that, and we have already sensitized and detailed discussion took place in 57th of Drugs Consultative Committee. I am also one of the member, but retail and state and retail and outlets and important wholesale pharmacies are dealt with all respect to state licensing authorities across the country. Law is the central law, but Drugs Control General India putting efforts with the close coordination with all principal secretaries of health to sensitize all licensing and controlling authorities for avoiding such a type of OTC, prescription and other important misuse of antibiotics, and in order to avoid antibiotic resistance, where one of the important global threat I already explained. So things are in the process. Definitely we are going to cover and taking all necessary steps with respect to having patient safety in toto as per the new bill is concerned. Thank you, sir.
But the problem is that when the drug control of India gives approval for the trial, it is not implemented at the state level, sir. Because state level, most of the time health ministers are non-medical, and the government sector hospitals are not being allowed to enroll the patients. And if at all any doctor enrolls the patients in the trial, they have been given memos and things like that. And second question is, sir, we should not allow the drugs approved in other countries, like FDA approves in USA, ESMO approved in European countries. In China, sir, for example, if the in the multinational trial, that China is not being included, they will not allow the drugs to be sold in their country. So also we should not allow the drugs which are approved by America or European like FDA or ESMO, we should, because unless we have our representative sample, because some drugs have benefits in some races. So, and also it will help our patients and our sectors. Actually, after the engineers have brought a boom, but after that, what was predicted was medical trials would replace that electronic boom, but that has not taken place because of this discrepancy, sir. I request you to comment on this.
Sir, good question, because whatever trials are being approved by the headquarter, that is new CDSU headquarter New Delhi, Drugs Control General India, that is CLA responsibility. But sir, when we give the approval for the clinical trial across the country, now as per the NDCT rules, local drug inspector can also accompany with our drug control officer when we go for the trial inspection. But we are also intimating with one copy of the trial approved by the DCGI to respect to state licensing authority. But they are neglecting, and that is the question. I also agreed, but now NDCT rules covered, and we are going to have the crash program with respect to inspection of all trial sites, because during pandemic session we face a lot of difficulties. That I also can understand, but sir, with limited manpower, the manpower is the question. So we are putting efforts, and we are going to meet all the important challenges with respect to the clinical trial sites, investigators, co-investigator, ethics committee members and all. So this we are going to sensitize, sir. Probably ICMR may take a separate training session for all clinical investigator sites and ethics committee members in Delhi. March 2023, we are planning to have 1 week session with respect to covering all important ambiguities as far as clinical trial protocols are concerned to meet GCP for ensuring well-being, protection, rights with respect to trial subjects involved in various clinical research programs. And that is second point, China, European Union, because whatever drugs are being approved, no, that racial differences I can understand. As I am also pharmacologist, I can understand the species and regional issues and our important population within the country, sir. When we go for the approval, ethics, because no, they will identify only 4 or 5 sites in our country. So we always tell, because no, Northeast people behave differently. South India people differently, they will behave differently. Western part different, north part different. So within the populated country, we are also having equal distribution as far as trial sites are concerned before going for the approval, as per the recommendation of the subject expert committee for various trial protocols. We are putting effort, but other countries, it is a policy matter. Definitely, Health Ministry is in the process to have harmony, how we can weed out other countries and what are the challenges with respect to global clinical trial. That checklist also is in the process to incorporate such type of important countries, those who are not involved, and sometimes they are involved, but they are not cooperating. These are all the challenges with respect to clinical trials. Thank you.
Ladies and gentlemen, can we give a huge round of applause? I'm sure a lot of questions are running in your mind, but because of the time constraint, we'll move on.
He is a very busy man, but giving so much time is also something which he does normally.
Absolutely. Thank you so much, sir, for your time.
Definitely, sir, because if IMA takes lead, I will have the one-day session full, morning to evening. If possible, night 1:30, no problem. I'll put my effort with the support of Rajgopalji. Thank you very much.
Thank you, sir. I request everybody to please be seated. Now the next speaker will touch your hearts. A cardiologist by profession, Dr. Sridhar Kasturi. I invite him to give his, I will say brief because we are running short of time, but Sridhar is very lucid and very humble gentleman, and he will complete this topic as fast as possible. Thank you. Dr. Sridhar.
Yeah, good afternoon, everyone. Thank you, Rajgopal, for giving me this opportunity. I thought I'm going to talk to common people. I was not aware of this one. So had I known, I would have prepared some motivational slides to even students also. But anyhow, I will touch upon. If you see the global burden of the cardiovascular illness, this is the most common cause of sudden death. If you see any death rate, if you see the maximum number of patients die because of the cardiovascular illness. It contributes to 17.3 million deaths per year globally. And if you see, almost 35%, more than 35% of the mortality rate is contributed by cardiovascular illness. As per the 2000 statistics, if you see the major non-communicable risk factors contributing to the death, hypertension scores above all risk factors. If you see the smoking, like tobacco, diabetes, and these are the major contributors of mortality. So anybody who is taking care of the hypertension, anybody who is taking care of diabetes, obesity, hyperlipidemia, almost saving maximum number of lives. So all doctors, all common people should be aware of these issues. That is very important. Do you know how many years it contributed? If you see in the last 20, 30 decades, the lifespan prolonged more than 10 years. But if you see the statistics, cardiology contributed to almost 7 years in that 10 years lifespan. 50% is due to a good exercise, balanced diet, and abstinence from smoking. So 50% because of the lifestyle. So if you change your lifestyle, you can prolong the life span by 5 years. And wonderful drugs have entered into the market, and antiplatelets, beta blockers, ACE inhibitors, statins prolong the lifespan for another 5 years. Interventions like angioplasty and CABG contributed to 10%. Do you know how much oncology contributed? Only 2.4 months as per the statistics, the lifespan prolongation. So the burden is very, very high. If you see the black bar chart, if you see in 2020, see compared to communicable diseases and other non-communicable diseases, injuries, the cardiovascular illness scores above all in contributing the mortality rate. So as you all aware, annual GDP is growing and literacy is rising. India poverty is gradually declining. So these are the important features one should understand. Similarly, globalization is taking place. That is contributing to more and more innovation, communication, and transportation. We are also influenced by the West, and more people are habituated to indulging in a more calorie diet, sedentary lifestyle, using more four-wheelers. And this is a changing pattern of the consumption of the food. So always we should change your consumption of the foods, and you should cultivate the good lifestyle modification. So here what is happening? So more and more urbanization, so decreased physical activity and more calorie consumption and high white diet and increased stress because of the urban lifestyles. All these are contributing to increased cardiovascular illness. So as you all aware, heart attack is due to the occlusion of any one of the major coronary artery. If the major blood vessel is closed, naturally that area is under threat, that lead to myocardial necrosis. If major epicardial artery is proximally occluded, large area of myocardium is damaged, that time patient can die. Suppose if he is not dying, even if he is surviving, there is a chance of developing a LV dysfunction, future congestive cardiac failure, patient may develop arrhythmias, and arrhythmias and sudden events can take place. You should be aware of all the symptoms. Unusual symptoms you should be familiar. Patient may have sometimes only shoulder pain, sometimes may have a gastric discomfort like acidity, sometimes only bilateral wrist pain. These are unusual presentations, so you should be familiar with this one. Particularly posterior MIs, they may have like a recurrent belchings, they may have a vomiting sensation, they may not have any chest pain. Elderly people, they may present with only confusion, they may not have any chest pain or difficulty in breathing. So these are the unusual presentation. So indirectly, larger the area, higher the risk. So whenever it occurs, you have to determine, take the ECG, because medical graduates are there. So more number of ECG leads elevation is there. If higher the ST elevation, the risk is more. Only 1 or 2 leads are there. Always take vitals. Vitals play a big role. Any alteration in the vitals, like blood pressure is falling, low pressures, if the rate tachycardia is there, extreme rate bradycardia is there, patient, because of the lack of perfusion of the organs and skin, so they may have a cold and clammy extremities. So altered vitals, extreme rate like a too high or too low, low blood pressure and very cold and clammy extremities, suggestive of tachypnea, is suggestive of pulmonary edema. So when these features are there, suppose if the patient vitals are fine, pain mild and ST elevation limited to only few leads, you can say very clearly this patient will come under mild to moderate risk compared to the person who is having a very low pressure and altered vitals comes under very high risk. As you all aware, atherosclerosis, the lipid deposition, the plaque formation in the coronary artery, gradually it becomes fibrotic. As the time passes, it will be converted into calcification, calcific plaque. So always try to prevent the atheroma progression. How to prevent the atheroma progression? Only good diet, good exercise, and risk factor control. So if you see the coronary artery disease history, 25 to 28% of CAD patients, they die suddenly. Before reaching a hospital only, they may die. 50% of the deaths will take place within the first hour. And among the survivors, those who survived, annual mortality rate is about 10%. That means significant, 5% thereafter. Why it is very important in India is South Asian countries are more prone compared to European and Americans and Japanese. So we are almost 6 to 7 times more risk compared to the Japanese and Chinese. And most of the time, our Indian patients are going to suffer from more and more vessels, more LV dysfunction. They come in late, and the disease manifests 1 decade early. That is important. And it also affects, atheroma is only one disease. But if it affects the peripheral blood vessels, patient may have a gangrene, claudication, and if it is a carotid, patient may lead to CVA, or if the renal artery, patient may have a renal artery stenosis leading to renovascular hypertension or chronic renal parenchymal disease. Sometimes they don't have a symptom, sometimes they may have effort pain, sometimes sudden death may be the first symptom. So you should be familiar with the causes. These are the common, these are only risk factors. So if more number of risk factors are there, the chance of having a disease early, that means at a younger age and more severe, the possibility is more. Suppose if the high cholesterol, high blood pressure, smoking, obesity is there, if more stress is there, lack of physical exercise, all these will contribute to coronary artery disease. The common pattern, the truncal obesity or apple type of or pear shape of obesity, the pot belly, so it lead to insulin resistant diabetes and sympathetic activity more, high blood pressure and insulin resistant diabetes and high triglycerides and very high density LDLs are very, very high in these patients. Cigarette, as you all aware, please avoid smoking. If you are a smoker, stop it. If you are not a smoker, encourage others to stop smoking. That is a very important issue. There is no not even single benefit with the smoking. So if the smoker stops after heart attack, by the end of 2 years, the risk is as equivalent to as a loss of weight, exhaustion, loss of taste. There are so many disadvantages, respiratory infection and GA cancer, or bronchogenic carcinoma, all other risk factors, it will contribute to all other risks. So when the smoking is there, suppose if the patient is eating more, like a sedentary lifestyle, and physical activity is less, and patient may develop insulin resistant diabetes, and as the weight increases, it may lead to hyperlipidemia, hypertension, and all will lead to atheroma progression. So these are all silent killers: hypertension, diabetes, hyperlipidemia. In majority, 80% of the patients, they don't have a symptoms. So that's the reason we neglect. But if you check accidentally, most of the time these risk factors, particularly as the age advances, always undergo the periodical checkups. Is there any high blood pressure, any diabetes is there, any hyperlipidemia is there? If you address these, and at the same time, regular exercise, very important, and balanced diet, very, very important to prevent as per the WHO recommendations, as per the International Society of Hypertension guidelines, the blood pressure should be maintained less than 130/85. And suppose if we are reducing the blood pressure by systolic blood pressure by 10 and diastolic by 5 millimeters of mercury, there is a 50 to 60% reduction in the risk of death due to stroke. Benefits are very significant, very well proven, and there is a 40 to 50% reduction in the risk of cardiovascular death. So cardiovascular death and stroke is going to be reduced very significantly, and and suppose every 10 millimeters of rise in systolic blood pressure, there is a twofold increase in the risk. So, and another thing, even if you reduce 2 millimeters of blood pressure, so over a period, it decreases the ischemic stroke and as well as the cardiovascular related mortality. What are the benefits if you control the blood pressure? There is incidence of stroke reduced by 35 to 40%, and myocardial infarction is reduced by 20 to 25%, heart failure is reduced by 50%, and dementia, the loss of memory in elderly, is reduced by 50%. The overall cardiovascular risk, we are going to reduce it by 16 to 40%. Even if you reduce like a borderline pressures also, bringing it down to normal also, you are going. This is based on the SPRINT trial, and weight reduction contributes to 5 to 20 millimeters of reduction, and DASH diet, that means eating more green leafy vegetables, high fiber diet, and low fat diet definitely reduces the blood pressure, and more potassium containing fruits and vegetables also helps in reducing the blood pressure. Increasing the physical activity also reduces the blood pressure. And hypertension, if you see the hypertension pattern, out of 100 patients, only 15 patients are taking adequate treatment that is under control. So majority of the patients, either they may not be undergoing the diagnosis. Many times, even if they are taking treatment, the treatment is not adequate. You are not eliminating the risk of hypertension. So thereby, you are not passing on these benefits to the patient. That is very important. And the global burden of diabetes steeply rising, particularly Southeast Asian countries, including India. There is almost a 40% increase, 40 to 32% increase of the diabetes in Indian subcontinent. So what are the leading risk factors? As I mentioned earlier, diet plays a big role, and high blood pressure, even air pollution. During COVID pandemic, they noticed a very low incidence of myocardial infarction because of the lack of air pollution. So that has to be paid attention. So because the already time getting delayed, I will try to expedite, and I will highlight some of the important features. When you take a diet, please pay attention to your diet, because diet is like a fuel. So you have to take a very good diet, because take more green leafy vegetables, try to consume as many portions of fruits, and try to reduce the carbohydrate intake, and fat intake should be reduced. At the same time, protein intake should be introduced. Fiber is very important. So fiber should be taken because it improve the gut motility. It also reduce the cholesterol levels. So even when you do when you take salt should be consumed very less. So don't add extra salt to the food. When you take more salt, what happens? Then chance of hypertension, cardiovascular mortality is going to increase. And alcohol should be as far as possible, my advice is avoid alcohol. Even if you don't take more than 2 pegs. That is ideal. If you take more, it can lead to atrial fibrillation. It can lead to alcoholic cardiomyopathy and alcoholic. There are so many side effects, including cirrhosis of the liver, as you all aware. So oils, you can mix the oils. You can combination of the sunflower or gingerly oil, olive oil. If you make a combination, that will give all subset of the essential fatty acids. That is very important. And exercise. So always at least make a habit. It should be integral part of the doctors. Particularly doctors, they lead with many emergency. You have to go in the night to do many emergency procedures, particularly when you take a high risk subset cases. At that time, even overnight, you have to stand 3 to 4 hours. So you have to maintain physical fitness, stamina. So that's the reason. Don't forget to do exercise at least 45 minutes to 1 hour to maintain your physical integrity. That's it. So sound mind in sound body. Only if you have a good health, then only you can think nicely and with positive thought. That is very important. So this kind of exercise, don't indulge. Please try to give a real impetus to your exercise. And suppose if you are, you may think that you are too busy. Suppose if you are going by bus or you are going by flight or train, whenever you are waiting, that time at least to try to make, during working hours, whenever you are free, try to walk for at least half an hour to 45 minutes. Suppose if you are able to park slightly away from your working place, keep a little away and try to walk so that you make it an integral habit. And diabetes also a dustbin, your body. Don't dump everything into the body. Please careful about the diet, because if you take anything excess, because nature will not forgive, it will become poisonous. So that is very important. And you see the obese teens are the incidence is steeply increasing. But we have to pay attention, particularly diet and exercise. These are very important. So if you maintain slimness, your overall look will be better, your fatigue will not be there, and definitely your performance will be better. All these things are advantages. So no need to think that I have to go to gym and do like a dumbbell or weights, pushes. All these things are not it. Even if you make an attempt to make at least 30 minutes of walking or swimming or jogging, whatever it's possible, try to cultivate that habit. And smoking, please avoid. Please discourage everyone from smoking. That's very, very important. All side effects are there. And another thing, this is very, very important. The cholesterol, you have a ugly cholesterol, bad cholesterol, good cholesterol, deadly cholesterol. We say HD cholesterol is a good cholesterol. Female should have a more than 50. Male should have a 40. If 1 milligram of HDL is increased, there is a 2% risk reduction. This is statistically proven. Suppose if the patient is having a 35, if it is going up to 40, you are reducing the risk by 10%. Similarly, LDL for every 10 milligrams raise, there is a 5% risk reduction. So try to maintain, if the diabetics less than 70 LDL, if non-diabetic maintain 100 below, and triglycerides should be maintained 200. If you maintain these values, definitely the cardiovascular illness becomes less. And this is a statistic, 10% reduction of blood cholesterol produces 20 to 30% decline in cardiovascular death. Initially, try to do the lifestyle modification, that is exercise and diet. Still, if it is not controlled in 2-3 months, try to opt for statin therapy. Most of the time, you can reduce the cholesterol levels. So these are the values you have to maintain. Blood pressure, try to maintain 120/80. At least it should not be more than 130, and its diastolic should not be more than 85. And the diastolic pressure should not be below 70 also. That is very important as per the recent guidelines. So blood sugar, fasting should be below, at least 110 below, less than 140. And if you maintain the blood sugars low, the risk of diabetes are very, very low. Sometimes we see many patients, they'll be asking, sir, I have a very strong family history. How to, so they are worried. Instead of worrying, you think that God has given a way to live, that they have to lead a disciplined life, eat healthy, eat regularly, walk regularly, watch your weight, and quit smoking, keep your weight under control. In addition, improve your heart. These are very, very important features. But these are the important factors they have to consider in implementing their day-to-day activities. Personality. Don't be over-aggressive, over-competitive. These belong to type A personality. As you all aware, type A personality is with increased cardiovascular death. So always avoid stress. Stress is definitely, it's like a matchstick. If you increase the stress, it burns the body. So don't try to avoid stress. Even in exams also, relax, read, put the best efforts. You write the exam, but don't burn unnecessary, don't create stress. By creating stress, you are not doing anything. And overall, you are decreasing your performance. Thereby, the chance of failure are more. So stress should be avoided. As these studies have shown very clearly, if the stress is more, the cardiovascular death is very high. So be friendly, and at the same time, be cordial with everyone. Thereby, you can read. If you have a healthy atmosphere in working place or you are in friendship, naturally the stress will be less, so that you can reduce the cardiovascular incidence. So contrary to the science, the advertisement is different. So what happened? There are more advertisements to colas, sugar drinks, chips, salted, pastries, and bakery items. So all these things, naturally, you are the acolytic reflex. Once you see it, you are tempted, but to control your reflexes, you decide. You have a very good brain. You can choose what is right, what is wrong, and accordingly you can maintain. Onion and garlic, very helpful. No need to take supplemental tablets, but you make a habit that these are part of your cook items. That is very important. So salt, avoid. Just by salt reduction and tobacco reduction, there was a reduction of 13.8 million deaths. You can avoid it. So this is an important factor. So finally, 2 slides are there. And by lifestyle, that is big 5. Not smoking, you are reducing the 28%. Exercise 30 minutes a day, you are going to reduce it by 17%. It also reduces the blood pressure. It also reduces the cardiovascular disease. And maintain ideal weight. Maintaining ideal weight only just by cutting the diet. Don't control your weight. Diet plus exercise. That gives you stamina. Overall, your fatigue will not be there, and overall performance is there. When you do exercise, body will have endorphins. When endorphins are released, overall well-being will be better. Your positive thinking, positive attitude will be better. That's how you can, you will be very successful in life. And ideal diet, that is very important. And alcohol, don't consume more, and try to avoid the alcohol. That is also very important. So mainly, finally I conclude by saying that maintain good diet, maintain good exercise, control the risk factors, mainly hypertension frequently check, keep it under control, diabetes frequently check, under control. HbA1c, if 1 point is increased, 14% increase in the risk. Suppose if the patient is having 8 HbA1c, at least check HbA1c. If you bring it down to 1%, then you are reducing the 14% risk. You are adding a lot of value to his life. That makes a difference. So thank you one and all. The prevention is better than cure. Thank you once again.
Well, sir, I do have a complaint with you. You almost negated all the things which I eat regularly to have a healthy heart. It looks like I have to start my life from the beginning. We'll try our best. I'm sure all the youngsters over here will agree to me that half of the things we have mentioned is our daily diet.
Topic for the coming generation. Rampant use of antibiotics has led to many drugs being lost for our healthcare. now request Dr. who has been fighting for antimicrobial resistance and antibiotics for a long time, to present his address to the gallery. Thank you.
Good evening all, especially my young colleagues. A very warm greeting from Infection Control Academy of India. The colleagues, senior colleagues who are sitting from IMA and our Deputy Drug Controller, Ramkishanji, and the organizers. Thank you very much for giving this opportunity in order to bring out some spotlight onto an issue of not only national concern but a global concern, that is about antibiotics. Antibiotics, today my topic would be to talk about the use, the misuse, the resistance, and also the containment of that resistance in order to ensure that we are going to have these magic bullets available for the future generations. When antibiotics were invented, everybody talked about them as magic bullets. I am sure most of my senior friends would know, but for the young generation to know, they were considered as magic bullets. So today, before I start on my presentation, maybe you can see on the screen, you can see a beautiful hero and also a beautiful villain also. When it comes to antibiotics, what do you think? Are the antibiotics the villains or the heroes? I don't see any of you actually responding. I see most of you are busy with your mobile phones and chatting with each other. If you could give me 20 minutes of your attention, I would be really grateful, and you would be grateful for your future practice, because most of you are medical students. I am sure knowing a little bit more about the antibiotics is definitely going to serve your future patients in a better way than what we are doing in our generation. So we'll come back to this slide a little later. But since most of the participants today are the young future medicos, let me give a little bit of brush up on a few terminologies which we frequently use about the antibiotics. What is, first of all, antimicrobial? Antimicrobial is any agent which is capable to perform against any microorganism. That is what actually antimicrobial is. It could be the antibiotic, it could be the antiviral, it could be the antifungal, anti-malarial, anti-parasitic, etc., etc. They can be produced biologically by microorganisms, or they can be produced by other synthetic process by the chemists. Ramkishanji has given a detailed note on how the pharmaceuticals, when we talk about pharmaceuticals, they are predominantly the chemical products which are synthesized in the labs. So they can be broadly two kinds. Either they kill microorganisms, then we call it as bactericidal or microbicidal. When they are able to just inhibit the growth, we call them as static or bacteriostatic or microstatic. Then comes to the question of antibiotics. When we talk about antibiotics, it is a type of substance against purely bacteria. That means it doesn't act against any other microorganism like virus, the fungi, etc., etc. Clinically effective antimicrobial agents, they usually work by mechanisms that inhibit essential processes in bacteria, unlike antiseptics, because antiseptics, they don't have a very specific target, and hence when you are using antiseptics, you usually have very high level of toxicity and hence they are not usable for most of the purposes. What are the main types? They are broad spectrum antibiotics, which means they have the activity against both gram negative and also gram positive species, or the narrow spectrum drugs, which is becoming very essential nowadays. Why, I will come to that a little later, has activity against only one group of microorganisms or only one species of microorganisms. Then comes another very important thing is therapeutic index. What does it mean? It means a level of selective toxicity of a given drug comparing to the blood concentration at which a drug can give the therapeutic effect. That is what is therapeutic index. So with this, probably we have set the tone. Now let us understand what is the classification of these antimicrobials. They are predominantly given by their action. They can act on the cell wall. They can also inhibit the cytoplasmic membrane. They can inhibit the protein synthesis. They can inhibit nucleic acid synthesis, or they can also actually act on the metabolites or the antimetabolites. That is how broadly by their action they are being actually defined and classified. They can vary according to the targeted microorganisms. That is, we talked about antibiotics, antivirals, antifungals, etc., by their molecular structure, their antimicrobial mechanism, etc. So now, since we have set the tone and understood the broad contours of what are the antimicrobials and antibiotics, now let us look at why do we need these antibiotics? Why do we need? That is a question we need to ask, because unless we ask this question very frequently in our practice, we are going to do missteps, which is going to be very expensive for our globe and in general for our healthcare system. Nearly half of the hospitalized patients, as you know, or probably you would know in the future, receive the antimicrobial agents. Either they are antibiotics, antivirals, etc. Antibiotics are valuable discoveries of modern medicine, and probably we cannot imagine our healthcare system, our current healthcare system, without having the antimicrobials. Because that is the kind of very important role they play in day-to-day delivery of our function as the doctors, nurses, and other healthcare workers within the healthcare ambit of the healthcare system. All current achievements in the medicine are attributed to use of antibiotics or, in general, antimicrobials. Probably it would not be a overstatement if we say that. And definitely the life-saving for most of the severe infections which we see within our hospitals. If we just go back into the origins of the antibiotics, it had been invented by chance, as you know. Would you know, who is this person here? I'm sure you all must know that this is Alexander Fleming, who very accidentally found out the penicillin. But when he saw actually that plate, he thought and he perceived that a fungal contamination of agar plate with Penicillium rubens inhibited the growth of bacteria. But then, of course, later on, everybody realized in itself it has got a potency that, to kind of inhibit, not only inhibit the growth, but also to kill the microorganisms. The antibiotics, as we all know, are the natural substances produced by microorganisms. That is one type. They can be the penicillins or the tetracyclines, which are not really much in use nowadays, but they used to be the main products, about 2 to 3 decades back. And then semi-synthetic antibiotics, which are kind of modified natural products. They are amoxicillin, doxycycline, etc. Then there are pure synthetic antibacterial agents which are chemically synthesized, probably you would all know is ciprofloxacin or any other fluoroquinoline for that matter. The working of the antibiotics, they work by very selectively acting on bacteria, or they bind to target molecules present in bacteria, binding to target to inhibit essential cell functions, which we talked about in the earlier slides. And of course, along with these effects which it produces, that is either being a bactericidal or bacteriostatic, they also produce a lot of side effects based on which product. For example, the kanamycin kind of products, which is an aminoglycoside, can have the impact like hearing loss, kidney damage, etc., etc. I would not go through this slide because it is a universe of all antibiotics and antimicrobials which are currently available. These are all the classes and the targets. Probably I will leave the presentation with the organizers, whoever wants actually, they can access it. You can go through each of those antimicrobials and the antibiotics, what are the classes and how do actually, which is the structure within the microorganism they target in order to achieve the intended therapeutic effect. So now, what went wrong with these antibiotics? We talked about them being as silver bullets, life saviors, or multiple other names what we gave. But what went wrong? One is we have started taking them for granted and started treating even the trivial infections like kitch in the gully, that a slight sore throat, we immediately go to the medical shop and buy amoxicillin. If it is only to that extent, it is okay. Even our own brethren within the medical fraternity, they indiscriminately kind of prescribe antibiotics for even viral infections where there is no place for the antibiotics. Many use antibiotics without knowing the basic principles of antibiotic therapy. Again, if it is a lay person who doesn't know, that is okay, but we as the medical professionals, if we are not going to know the basic principles and start prescribing indiscriminately, that is going to bring us into a catastrophe, which I am going to talk in further slides. Many medical practitioners are under pressure for short-term solutions. Many of the doctors, when we talk in private, they keep saying, what to do. The patient has come and they started demanding actually the antibiotics. Yes, that is the reality. But I think, with a lot of patients, I think, we should take up the role of a teacher or a propagator in order to educate the patients so that, they don't demand antibiotics or they don't actually push you to prescribe something which is going to be detrimental in the long run, not only for the given patient, but also for the society and the community at large. And of course, one of the other factors is the commercial interest. We all know very well that the pharmaceutical companies have got their own targets. They want to achieve their financial targets, and they try and create an environment where they are going to push for the higher number of prescriptions by each of us as doctors. Then the poverty is another factor which also made antibiotics go wrong. Why poverty? Where does it come from? Very simple, that when there is a daily wage laborer, he or she would like to go back to the work as soon as possible. That means they would like to get the treatment instantaneously so that they can recover very fast from that infection and go back to their work so that they don't lose their daily wage or their livelihood. So now we have talked about the good part of it, and also we talked about what are the mechanisms, etc., etc. Now with the intended effect, that is the therapeutic effect, we also have intended effect, that is the resistance which has formed over a period of time for all these antibacterials, antimicrobials, antibiotics, etc., etc. So, very briefly, what is antimicrobial resistance? It is the ability of the microorganism, like every living being, it also wants to survive and also to grow. And hence, they would try to do every trick possible under their hood in order to survive and find a way in the presence of that chemical or a drug, how to survive and also, to produce the progeny. That is very natural. It is either human being or a microorganism, any living being would do that. What is the impact? Impact is understandable that, it makes our life very, very difficult to treat the infections which otherwise we would have been able to treat with all these arsenal of antimicrobials, antibiotics, etc., etc. And in most cases, what we see is now the age-old infections like gonorrhea, tuberculosis, etc., etc., which we used to treat with very simple antibiotics, we are unable to treat them with even advanced antibiotics because of this bacterial resistance. Why this phenomena called antimicrobial resistance happens, or why does it develop? I think we spoke about it very briefly, but I would repeat for the sake of understanding once again that while the microbes are going to evolve constantly and survive the difficult conditions by adapting to new environments, they definitely get used to those chemicals which you introduce as antibiotics, and hence actually the AMR develops over a period of time. And considering this fact, World Health Organization has put up a list of essential medicines. I am now again going into the territory of Ramkishanji. The essential medical list is predominantly prepared by the pharmacists, and World Health Organization has in 1977 itself has prepared the first list of essential medicines where the antibiotics have found their own place, and that had been in revision every 2 years. The last one was done in 2021, and that list contains almost like 37 antibiotics which are considered as essential in treating 26 common and severe clinical infections, predominantly focusing on low and medium income countries, because these are the countries where we need to have a large arsenal of antibiotics which are going to be available, because by the nature of these countries where the resources are very limited and the poor settings create a breeding ground for all kinds of infections, you need to have these essential medicines available all the time. And when WHO understood actually the magnitude of the problem, they have divided the available antibiotics into 3 different sectors. One is the access, the watch, and reserve categories, so that you don't use all of them at once. It is like in the war, you don't use the Brahmastra in the beginning itself. You would keep your Brahmastra to be used in the end when all other things are going to be, not working, right? It is the same way that initially you had to use small weapons, then medium-sized weapons, then you are going to go into nuclear weapons or the Brahmastras. And the reserve group is like your Brahmastra group, where you are going to use them only when all other things are going to fail, or you are going to keep them reserved so that you can tackle with the infections in a right way. This is what is the AWARE classification. I would not read through them, but in kind of essence of it, I already have given. Access is, which is going to be the list of antibiotics which are going to be available for every healthcare worker. That is, either it is a physician, in some countries actually the pharmacist to prescribe, in some countries even the nurses actually have the access to the access, and also they do prescribe some of the antibiotics, and this is available broadly. And then you have got a watch group. That means if you don't have intended effect, intended therapeutic effect from the access group, then you shift into the watch group, and when the watch group fails, then you will go into the reserve group. Let me actually not go into the detail of it, but if you talk about, let's say, reserve group, that is, the penems like aztreonam and cholesterol, linezolid, etc., or tigecycline, these are the things, which are reserved. But unfortunately, in Indian scenario, even in villages, the so-called RMPs, they start with these kind of antibiotics, which makes actually life very difficult when they are referred and they come to the tertiary or secondary care hospitals to treat those infections, because you have put all your brahmastras already. You don't have anything available in order to treat these patients. So that is where the question of IMA, always comes. IMA keeps saying that, regulate these people, because they don't know what they are actually using. They don't understand actually the mechanism of these antibiotics, and they are using or misusing, which is making the state's healthcare or the national healthcare, putting that into jeopardy and the danger. That is the reason why IMA keeps actually talking about the quacks. It is not because of the jealousy they have. Most of the times the people say that, it is the professional jealousy, that's why they are attacking them. No. It is the question of actually using the right products for the right person in the right dosage, so that you can save those lives and keep them well. That is the reason, the IMA keeps fighting for it. And when it comes to this antibiotic problem, one of the things, which definitely need to be mentioned is, it is not only about the quacks. Even the practitioners who are registered medical practitioners with the medical council, they also do mistakes in terms of actually identifying the actual need for antibiotic. Does actually antibiotic needed in every case when you are prescribing? The international studies and also the national studies show that there is a disbalance between them. Disbalance between the usage and also the actual need. That is what actually is again producing kind of unintended effect on the whole of the healthcare, and the solution is to reduce the antibiotic usage on one side, and the other side to align reduced usage with the actual need. So, just to illustrate the pattern, it is not only about actually usage within the human sector. Antibiotics, probably as you would know, is very widely used in the animal sector. It is used in the agri. It is used, in other areas, including, let's say, fish farming, the aqua farming, etc., etc. So, when we broadly look at actually the antimicrobial consumption, 50% if it is human consumption, 50% would be the animal consumption. Within the human consumption, only 20% are being used within the hospitals. Only 20%. Means if you take number of prescriptions, every fifth prescription is antibiotic, and that is given in hospital. All other four, the users, they take the decision on their own and use it in the community, which is again becoming a problem. That is what is the question which was posed to Dr. Ramkishan, that how do you regulate the over-the-counter dispensing of these antibiotics, so that we don't see this kind of scenario where 80% of these very valuable drugs are being misused at the community level. And 20 to 50% of them, as per the international studies, are unnecessary. Unnecessary. That means they are being given just like that. So, which if it has no unintended effect, then it's okay. But they are not, lollipops just to take it, or they are not, eclairs or, Cadbury chocolates just to pop them just like that. And if you look at the animal sector, again, 80% of the antibiotics or the antimicrobials are used for prophylaxis. Can you understand? Prophylaxis. Antibiotics are being used for prophylaxis, which is very highly questionable. And definitely the rules had to be changed in order to ensure that that kind of situation is not going to happen in the future. You are the future. And the life is yours going ahead. So you probably are the guys actually who had to come forward to ensure curtailing this kind of unnecessary usage, especially as a prophylactic or growth promotion within the animal sector. I would not go through this integrated system of antimicrobial stewardship. Whoever is interested, they can actually come over, we can discuss in detail about it. The dangerous bugs, I talked about the WHO priority pathogens, which are developing multi-drug resistance and now pan-drug resistance, and hence they are being defined as critical, high and medium kind of, a list. And these are the indication actually for the drug manufacturers in order to understand what are the new inventions which are to come in order to take care of, these priority pathogens which are not getting treated by the existing arsenal of antibiotics or the antimicrobials. Some of these slides probably, I would not comment, so I would be skipping, so don't mind about it. One point, I would like to concentrate on this slide is, while antibiotic numbers means their inventions and also the number of products which are available for the medical community, the resistance is also equally going up. If you look at historically, 1940s was the penicillin, when everybody was happy that, we are able to treat and play the god, for the dying patients, just giving penicillin, and they are back into their life. And that probably took about 10 years to develop the resistance. But if you look at historically, from 60s to 70s onwards, every antibiotic, which is coming into circulation or into the market, that is getting the resistance within no time. Now, the last antibiotics, which we have seen coming was around 1990s and 2000s. Within 3 years, you have seen actually the resistance being developed. And there are very few new drugs which are coming for the reasons of commercial, because when you have such a short span of only 3 years available for marketing or selling, no pharmaceutical company is interested to invest into research and development and get the new drugs. That means, we are going to have a very, very bleak future, very dangerous future where we will not be able to treat even simple infections. That's why we need to invest seriously in preventing the infections. And, we had been talking about it, especially, it is good that, corona or the COVID-19 infection has kind of had a silver lining, that it put into the minds of the people how dangerous and how catastrophic the infections can be. I think, that is one lesson, which had to really reverberate in our minds and also in the government minds in order to invest more and more into preventing the infections, so that, all that what we have achieved in the modern medicine can go on, like, keeping the surgeries safer, keeping organ transplants safer, keeping dialysis safer or the cancer care safer, etc., etc. What are the key considerations for optimal use? We talked about it. We had to ensure that we had to target the priority pathogens. We had to have, we had to overcome, the resistance. We had to also ensure that infection prevention and control and the WASH, that is water, sanitation and health, is taken seriously. We had to ensure that, the antimicrobial stewardship is taken seriously, so that the optimal use is going to be put in place, and we preserve the effectiveness of that arsenal which is life-saving for the humanity. So this is the breaking, this is the slide which I usually use towards the end of my presentation to grab your attention once again that antimicrobial resistance is a global problem, right? And it is in fact killing more people than oncology or some other diseases. When Ramkishanji was making a presentation, he talked about top 10 issues concerning the global health. One of them is antimicrobial resistance. If we don't stop it, world is going to pay a very high price. Already world is paying a high price. If you look at the Lancet publication, which has actually covered very extensively the 2019 patterns of AMR, where it has come out very clearly that more than 4.9 million people are already dying of antimicrobial resistance. And if we are not going to keep a stop, probably many more times this problem is going to increase and the mortality is going to increase. And not only the mortality, but also it is going to have a significant impact on the global economy, making the loss of trillions of dollars. So, broadly, I have covered most of the topics. I would come a little to our own scenario in India. When it comes to the global action plan, in order to handle the antimicrobial resistance, World Health Organization and the World Health Assembly in 2016 has brought out this global action plan on antimicrobial resistance after a detailed research and also the consensus of all the nations. And in this action plan, there are 5 major elements. One is the awareness, understanding, knowledge and evidence, infection prevention and control, optimal use, innovations, R&D, etc., etc. Taking that into consideration, India also has come out with its own plan in 2017, and we are currently working to map the stakeholders in Telangana in order to implement the state action plan. There are 4 states which are ahead of us, that is Kerala, Madhya Pradesh, Delhi, and the 4th state is our neighboring state, Andhra Pradesh. I hope with the stakeholders like IMA, the drug control, and all of you, we should be able to come out with this plan and ensure that we are not going to have this problem further escalated. Now you please tell me whether antibiotics are a hero or villains. Raise the hands, who think it is a hero. Absolutely, it all depends on us. We can make it as a villain or a hero, depending on, how we are going to make use of it. Be careful, ensure that, there is going to be optimal use in order to save our valuable lives of our patients, to save our healthcare, to ensure that the globe is going to be safer, and when there is a need, this arsenal of antibiotics are going to be on our side, not against us. Thank you very much for your attention.
Thank you, Dr. Rangareddy. This is one of the most important factors which our postgraduate students must take a point home, that antibiotics causes more damage now than the help. I thank Dr. Rangareddy, and I request Sabrina to please join me in felicitating Dr. Rangareddy. It is always the heart which is quite troublesome. We heard Dr. Kasturi. Now I request Dr. J. Srikanth, who is an internal medicine specialist and a physician from Apollo, to please address us on managing hypertension in adults especially.
sir? Third. Good afternoon, ladies and gentlemen, and then at the outset, my sincere thanks to the organizers and my special thanks to Dr. Rangareddy Garu for giving me this opportunity to be amongst you. Dr. Rangareddy Garu has given me a call about 2 weeks ago, and he wanted me to talk on hypertension. Well, I think it's just a notion for the benefit of the budding postgraduates and then the undergraduates who are going to be the physicians of this century. What I'm trying to do is just trying to pick up a few drops from this ocean and evolve few steps as to how to prevent, because that is the central so-called idea or theme of today's program. The earlier topic, as Dr. Rangareddy Garu has elaborated, was mostly on the communicable diseases, a facet of communicable diseases rather, antibiotics. Now I would be dealing more with the non-communicable diseases, the facet number 2, as Dr. Ramkishan has pointed it out. This is something which was a so-called mini pandemic during the later part of the 20th century, and it continues to be a mini pandemic in the 21st century, thanks to the occultation and the changing lifestyles having an impact, like development of diabetes, obesity, dyslipidemia, various other things. So it has become an important element of the lifestyle diseases. Hypertension per se is mostly polygenic inheritance. Let's start with India. We now have 22 crore population. Mind you, the undergraduates, please wake up. 22 crore population are hypertensives. And as Dr. Sridhar, my senior colleague cardiologist, has made it very clear, only 12% are under control. So you as physicians of the future have got an ominous responsibility of managing effectively the so-called dreaded disease. The worldwide statistics are even more greater. 1 billion people are being diagnosed as hypertensives per year, out of which 9.4 million deaths are occurring per year. The prevalence is more in people who are more than 60 years, and if you take the US statistics, 65.4% people are hypertensives, and it is predominantly more in blacks and non-Hispanics, Asians. So all of us, we are at risk. What is this hypertension? To recapitulate the definition for the benefit of the undergraduates, so normal blood pressures is around 120, less than that, and less than 80 millimeters of diastolic blood pressures. There was an element of a so-called statement which lasted for about 5 to 7 years as per the JNC 7 guidelines. Pre-hypertensives are anywhere between 120 to 129 systolic and less than 80 millimeters of mercury diastolic. Stage 1 hypertension is between 130 and 139 systolic and 80 to 89 diastolic. Stage 2, mind you, this is something that's beginning to become rather serious or dreadful, is anywhere between more than 140 and more than 90 diastolic. Mind you, this reading should be based on 2 or more seated recordings in 2 separate official visits or office visits. These days, there is a facility. In fact, there are lots of bodies, both from the pharmaceutical companies, they have come forward, and many bodies have laid down specific instructions to make best possible use of continuous ambulatory blood pressure monitoring, and they have even provided facilities to measure home blood pressure monitorings. This is very, very practical and quite useful in judging the patient. Why? I'm coming to that in my next slides. The nocturnal dip attenuation, the blood pressure usually drops in the evening or towards night, and then there is an early morning surge thanks to the steroids and various other hormones which give rise to this rise. So this is the physiological, as well as sometimes if it is extended, it becomes pathological. Any attenuation of this nocturnal dip followed by an early morning surge is extremely important, and it is a precursor for development of blood pressures and the ensuing CV events, the cardiovascular events. See, why is it important to know something about the mechanisms of hypertension? It is definitely important because various treatment options are available for us now these days. You have the pharmacological elements, the non-pharmacological elements play a very, very important role in the control of hypertension also. So, what are the mechanisms by which the blood pressure shoots up in an individual? Intravascular volumes, mainly the cardiac output, the vascular resistance, which is measured by the peripheral arterial resistance, the various hormones, the parasympathetic and sympathetic pulse, noradrenaline, then you have the other hormones which indirectly contribute to the development of hypertension. The renin, angiotensin, aldosterone system, and lastly the immune mechanisms, various inflammatory markers, the CRP, the various oxidative stress is equally important in building up the blood pressures. This has been notified or seen, observed in various autoimmune diseases like SLEs, RAs, where you have a disarray of autoantibodies and most important inflammatory markers like CRP. So this makes the treatment options quite complicated and intricate. What happens if the blood pressure goes up? As Dr. Sridhar has already elaborated, it is the end organ failure. The patient may have CAD, MIs, congestive cardiac failures, various types of tachybrary arrhythmias. When it comes to brain, you have ischemic and hemorrhagic strokes. Kidney also takes the brunt, either acute in the form of acute kidney injury or a CKD, the chronic kidney disease. Then you have the medium-sized blood vessels also getting affected in the form of the peripheral arterial disease. Not to spare the small vessels involving the retina, you have the retinopathies. So, hypertension in fact is a syndrome affecting all the vital organs. We need to classify hypertension because we need to treat. As I was mentioning, the primary or the so-called essential hypertension is mostly polygenic. Inheritance is polygenic. Various genetic factors, they contribute. Secondary hypertension, fortunately, is rare, but something which the treatment aspect is totally different. You can have the involvement of kidney giving rise to hypertension, the renovascular hypertension, then you have the adrenal gland getting affected, mostly the Cushing's or the pheochromocytomas involving the adrenal medulla. You have the primary hyperaldosteronism known as Conn syndrome. All these things may give rise to the secondary hypertension. The treatment again, mind you, is different. You need to tackle the primary cause rather than using the antihypertensives blindly. Coarctation of aorta, which is more a congenital disorder, where the aorta gets narrowed down either in the thoracic cavity or in the abdomen, may also give rise to hypertension. Then you have obstructive sleep apnea, which my next speaker is going to elaborate. He is one of the most important entities giving rise to hypertension. You have various types of endocrine abnormalities like the thyroid disorders, the parathyroid disturbances, and the growth hormone disturbances, which can give rise to hypertension. Can I have the silence over there, please? And various medications, mainly the oral contraceptive pills use, the steroid usage, and some of the antidepressants like MAO inhibitors. These are the things which might upset the balance and give rise to high blood pressures. The monogenic hypertension is extremely rare. It is transmitted genetically by a single gene. Mind you, that's extremely rare. There are other terms which are quite often used in the medical terms in the medical colleges. The white coat hypertension, the patient becomes, or you notice as a physician, the blood pressures getting elevated when the patient visits your office. This is seen in 15-20% of the people, but fortunately, the things become normalized when he goes back home. This need not be treated. Masked hypertension is exactly the reverse. The patient's blood pressure is normal at the official visit, but during his home blood pressure monitoring, the blood pressure shoots up. This is something which is dreadful. This you come across in 10 to 30% of the cases, mind you. So that's the reason the home blood pressure monitoring devices are extremely useful to pick up these things and then start managing. You have, of course, the gestational hypertension seen in the pregnancies. Resistant hypertension is a term which is selectively used when more than 4 drugs are being used and still the blood pressures are not under control, and this needs a thorough re-evaluation. The other term which I would like to emphasize is accelerated hypertension, when the blood pressure fails to get controlled despite using 3 drugs. Again, you need to change or adjust the dosing. Malignant hypertension is something which is a medical emergency, which I am going to deal in my next slides. So how are you going to approach the patient with hypertension? As a professor of medicine and a teacher, I would still emphasize, just like Dr. Rangareddy Garu, I would emphasize the need for the HNP, the history and physicals, to be taken, wherein emphasis is given to duration, family history, dietary and psychosocial history, smoking and alcohol consumption, other risk factors. Take into account when you see the patient personally, the body habitus, whether he is obese, medium built or thin built individual. Keep checking the blood pressures in both the arms and one lower limb and both the postures. The lying down posture, the so-called supine posture and the sitting posture. Look for all the peripheral pulses. This goes without saying. Whether it is 20th century or 21st century, whether you are dealing virtually, which has got its own limitations, but the real world practice of medicine would emphasize the need for having a proper HNP. And lastly, don't forget to see the thyroid, which would indirectly contribute, and the retina. Some of the lab tests would be helpful in eliminating or detecting the secondary hypertensions. I would quickly rattle when it comes to renal, serum creatinine, EGFR, the microscopic urine analysis, and the protein excretion. Look for the serum electrolytes. You may pick up the Conn syndrome. TSH estimation, the thyroid profile would pick up underlying hypo or hyperthyroid states. Metabolic elements like fasting blood sugars, as diabetes is the sister of or the twin of the hypertension in the present day lifestyle diseases, HbA1c and fasting lipids. I would also be interested in having a baseline CBC, EKG and 2D echo just to see the chambers of the heart. Treatment guidelines are very, very clear. You should target the blood pressures of less than 130 by 80 systolic and diastolic. The exceptions are hardly very few. Acutely ill patients and patients over 80 years. The geriatric populations, be extremely careful, and then you can relax these rules. Treatment, mind you, is highly personalized. It varies from person to person and it depends upon the associated comorbidities like diabetes, dyslipidemia, hypothyroidism. All these things, they play a very, very important role in deciding the drugs. You may have a patient with CKD. Again, the medications, the choice of medications is different. The combination of various methods, pharmacological and non-pharmacological methods, forms the mainstay when it comes to the treatment. Quite often, as established during the latest or the recent guidelines, you are supposed to use 2 drugs, one in the morning, one in the night, because no drug is effective for more than 24 hours. So, we believe in having 2 drugs at a time, or at least one drug in the morning and the second drug in the evening to counteract the nocturnal so-called attenuation and the early morning surge. I won't elaborate on drugs because purposefully I am starting the pharmacological ways of managing. I would come to the non-pharmacological ways a little later. Though, as a physician, you are supposed to elaborate the non-pharmacological methods first. When it comes to the pharmacological ways, you have the different class of molecules, diuretics, beta blockers, alpha blockers, the centrally acting drugs like clonidine, alpha-methyl dopa, AC inhibitors, ARBs, which are quite often used these days on the frontline drugs, calcium channel blockers, and next line is the vasodilators, both venous and arterial. You have hydralazine, sodium nitroprusside, but we reserve them. We don't use it quite often. Something about the device-based treatment, which I'm sure the future postgraduates of medicine would be interested. These are the methods, the carotid baroreceptor activation. You try to use the carotid sinus and then you activate it. This results in the drop of blood pressures. And you also have an endovascular radiofrequency ablation of the renal sympathetic nerves. This is where you try to, so you are trying to cut the so-called RAS axis and bring down the blood pressures. This is something which is highly reserved and which is done by the interventional radiologist and the cardiologist for resistant hypertension cases, not for all. Hypertensive emergencies, as I was mentioning, they do require hospitalization. You cannot manage it as an outpatient basis. Drugs, mainly we bank on the intravenous sodium nitroprusside, nicardipine, IV labetalol and nesmolol, predominantly the beta blockers, the fast-acting beta blockers, IV NTG infusions, hydralazine and phentolamine. These are the drugs which are reserved for the hypertensive emergencies. Now I'm going to come to the first thing which one has to advocate or preach and practice. The lifestyle modifications. Some of the things which Dr. Sridhar has already highlighted. The weight management, because you are dealing with the so-called panchabhutas, not the panchabhutas of air, water and these things. They are good. Here I am trying to look the other way. They are the villains, the 5 villains. Obesity, hypertension, diabetes, dyslipidemia, and of course the smoking and alcohol. So weight management is important. Decreasing the salt intake to less than 2 to 4 grams per day. Having or adopting the DASH type diet. Cutting back on ethanol and nicotine use, which my colleague Dr. Sridhar has elaborated. Acupuncture, this is something which is extremely interesting. It is a Chinese methodology, also brings down the blood pressures. There are various trials. People who are interested, they can go through and you can find them. This brings down the systolic as well as the diastolic blood pressures. Physical activity, any type of physical activity. Mostly, if people are not habituated to go to walking, please do it. Brisk walking is more than enough. Walking for at least 35 to 40 minutes per day, 6 days in a week, more than suffices. People who are much more tuned, they can go for aerobics. Others, I would stress, others are equally important. In fact, I am the person who has started off a trial incorporating yoga in managing hypertension. The trial is on with good results, which I am going to stress. The type of yogi kriyas or some of the asanas. Dance, music and meditation. Amongst the yogas, how does yoga affect the blood pressures? Alteration of breathing, alteration of the muscular tone, vascular tone. Extremely important in controlling the vascular resistance. The most important thing is the relief of stress. You have various yogas, asanas, balasana, that is the child posture, bending totally and falling asleep. This is a very, very important. You won't find the child, extremely rare to find the blood pressures building up in a child or an infant. Sukhasana, the easy posture which we adopt in the sitting posture. Bhujangasana is the serpent posture which I am going to show. This is the serpent posture which I am trying to practice, and I regularly practice these things at home. Shavasana is the corpse pose. You are lying still, just like a corpse. Setu Bandhana Asana, this is something like a bridge. And Adho Mukhasana, this is the one, is a mountain pose. People who are dancers, I find young girls, I know some of them could be dancers. So, I'm just projecting the slide, which my wife is a fetal medicine consultant and head of the department at Fernandez. She is a dancer. So, these type of activities, we keep doing it regularly, and our blood pressures are absolutely under control. Dance is something which involves all the muscles, heart and the mind. And when these things are tuned, the blood pressure automatically settles down. These are the ways of managing the pre-hypertensives, the stage 1 also. I am stressing upon, because stage 1, you may require 1 or 2 drugs. By practicing these things, the pill burden can be reduced. So that way, you are indirectly contributing to the preventing or promoting the disease or progressing the disease. Music is the one which I practice. I'm a musician too. So, some of the observations which I have started off as a trial, I'm just opening the things to you. It is swara specific, means the note specific. It is the combination of different notes, the ragas, which is highly selective. Just trying to open. I think you can hear this so-called Shruti. My laryngeal muscles are under control. My thoracic muscles, both the intercostal muscles as well as the muscles and lungs, are brought under control. It is the push and the pull of the autonomic nervous system and the release of the endorphins which contributes to the drop in the blood pressures. I have good number of pre-hypertensives who got incorporated voluntarily, whose blood pressures were brought under control with the use of specific notes and ragas. Some of the ragas, I think you are very familiar. If I talk in a Carnatic language, Khamas raga, Kiravani raga, and Kalyani raga. These are all the ragas, or the different combination of notes. To put you to the film music, तेरे मेरे मिलन की रहना हो, तेरे मेरे मिलन की रहना. This is based on Khamas. Sachinda has composed it way back 50 years ago. Tere mere milan kiye rehna. Even the lyrics are like that. Start listening to these type of compositions. Your blood pressures would touch normal. And of course, meditation. Need not be a singer or a musician. Having a keen ear is more than enough. You start practicing meditation. any form of meditation. It cools your mind and body. There is one note. Om Loka samastha sukhino bhavantu. Sarve jana sukhino bhavantu. Om Shanti Shanti Shanti. This is the Shanti mantra which advocates the wellness for all, and that is the theme for today's program. Thank you for the patient hearing. Any questions from the audience? You're welcome. It has been tried, sir. I think even I am not aware, but it is supposed to stimulate the peripheral nerves. And again, through the ganglia, again it is the autonomic nervous system which plays an important role in the connecting. More than this, I think I require the help of the acupuncture experts who are here. Yes.
Personal experience, and if doctors are very much interested, such specialists are there, they can introduce so that no one can beat allopathy in the future. Thank you.
My request to Ramkishan ji is, I have started the trial, sir, with ethical committee's approval. I am using music regularly in a certain section of outpatient basis, and my plans are to extend this to the second level, that is catering to the pre-op wards, the post-operative units, the ICU units, terminally ill patients, and finally, I think I'm going to go into the labor wards also. The trials are on at Apollo. Just wanted to. Thank you.
Thank you so much, sir. I think give a huge round of applause. He has not only given us a wonderful talk, but he has even performed for us. For that, I think he deserves another huge round of applause. Thank you so much, sir.
He has taken me back to my college days. 40 years before, we used to listen to lectures like this. This is something very lucid. I thank Dr. Srikanth for giving us a lucid lecture, and I request him to please accept our memento. I request Dr. T.V. Srinivas, neurosurgeon, to please join us on stage. Kindly make it fast, sir. And we have only 2 topics left with less time. The next will be diabetes. I request Dr. Srirang Ngapkari to please join us.
Thank you so much, sir, once again for that wonderful presentation. And I must say you are supremely talented when it comes to your singing too. And yes, we will definitely follow your instruction. Yes, our hypertension is relieved. Let us move on to our next speaker. Over to you, sir.
Download.
Good afternoon, everybody. I thank the organizers for this opportunity to share a few thoughts on both diabetes and newer insulin in primary care. My special thanks to Dr. Sanjeev Singh Yadav for this opportunity. Request all the audience to please stand up for a minute. Can all the audience stand up for a minute? I think one of the important factors in our day-to-day life which is contributing to diabetes is a sedentary lifestyle. Just to break the monotony of sitting which you have been doing for some time, just to stand up. So we all need to prevent diabetes, and then we have taken the first step by getting up from our chairs and then trying to move around. Thank you so much. You've been such a wonderful audience. Please sit down. Thank you. Diabetes in primary care is a very important factor which we need to take into account. India is now called as the diabetic capital of the world, and Hyderabad somehow is holding the distinction of the diabetic capital of India. So we need to take urgent steps to prevent, treat diabetes very effectively. Just yesterday at the Golden Jubilee Conference of the Research Society for Study of Diabetes in India, 2022 clinical practice guidelines by an Indian body have been released. I urge all of you to go through that so that we all manage diabetes in a very uniform and a practical way so that our patients benefit. Moving on to newer insulins. All of us are aware of these two wonderful Nobel laureates, Banting and Best, who discovered this important hormone, insulin, on 27th of July 1921, for which subsequently they received the Nobel Prize. And today, we have come a long way from treating our patients with diabetes, and such was the joy, as you can see in that newspaper that time, the headline reads, "Toronto doctors on track of diabetes cure." We are surely moving towards a good control of diabetes and maybe in some instances, cure or remission of diabetes, which I should call. What is this? Anybody? Lot of postgraduate students. What is this? Somebody wants to get up and say. What is this? Anyone? You have to overcome your inertia of getting up and standing. Let us make this an interactive session. What is this? Anybody? Am I not able to hear, or you are not speaking? What is this? All of us are aware that this is the molecule of proinsulin. We have the A chain, B chain, disulfide bonds, and the C peptide which is binding them. So insulin is a small globular protein, as all of us are aware, containing two chains, A and B, and it is stored in the beta cells as a zinc stabilized hexamer, and it dissociates in the bloodstream to function as a zinc-free monomer. All of us are aware that insulin actually facilitates the entry of glucose, so whatever we are eating is actually being utilized by the body only in the presence of insulin. So coming to newer insulin, while I was an undergraduate, we started using insulin which were animal insulins. We've had porcine insulin, we've had bovine insulin, then came the semi-synthetic insulin. Finally, you had the recombinant technology being brought into use in the production of human insulin, and now you have multiple insulin analogs. So what are the advantages of newer insulins? Because they are refined, because they are pure, you have less allergic or immunogenic reactions. The autoantibody formation to insulin is much less, so you have less resistance. They are very well tolerated, And because of the different tweaking which is occurring in the insulin molecule, they are actually being tailored for different category of patients. We're trying to mimic the physiological release of insulin in the body, wherein you have a basal insulin going on and then boluses for every mealtime insulin. Now you can have an insulin pen in your pocket and it becomes very easy to administer. The needles which are coming nowadays are very fine and it is almost a painless injection. People are scared about insulin because they feel that is end of the story. A lot of patients can be managed with diet and lifestyle modifications alone. Some will require drugs and then some will require insulin. However, insulin may be required early on itself when you diagnose diabetes. A lot of times when people come to us with health checkups and find a very high sugar, we give them insulin for a small period of time initially to rapidly control the blood sugar level and then switch them back to oral drugs. This is important because early control of diabetes is important because there is a concept called as metabolic memory, wherein your early control actually portends a favorable prognosis compared to a poor early control initially, which has a lot of complications later on. So as I said, the insulin will have less antibodies. Injection is associated with fewer skin reactions. They are more rapidly absorbed and less degradation occurs at the site of injection. The human insulins are developed by the recombinant human technology and are derived from bacteria or yeast, bacteria like E. coli. All of us are aware of the different types of insulin. It can be short-acting insulin, which is the regular insulin. You have the intermediate-acting, the NPH insulin. Then you have combinations of insulin where you have a mixture of the short-acting and the intermediate or long-acting, which is called as a premixed insulin. Whenever you write a premixed insulin, it is a good habit to mention what is the percentage of the mixture. Is it 30/70 or 50/50? Now, the human insulin is now being further modified by certain changes in your amino acid sequences to alter the property of the insulin or attachment of certain molecules to alter the release of insulin so that we get a desirable effect. So you have fast-acting insulins which act faster than the short-acting ones. It includes Lispro, Aspart and Glulysin. Now we have a very ultra-fast-acting insulin which is called fast-acting Aspart or Fiasp. You have a longer-acting versions called Detimer, Glargine, Degludec and then U300 Glargine. So by this, we are trying to have different effects of insulin so that we control the sugars by causing less hypoglycemia and which is more convenient. Somebody who is not sure of his meal time can use these insulin because this insulin can be taken with the food or sometimes just after food. Because if you take insulin and you are not able to eat on time, as we see in the doctor's profession where you get a call suddenly you have taken insulin, you are not able to eat your food on time, you are not at a risk of hypoglycemia. Because they act for a very short period of time, the risk of hypoglycemia again is important. There are certain professions where the hypoglycemia has to be minimized and therefore you need to know the type of insulin you are using, the characteristics and then use them appropriately. Regular insulins are generally given about half an hour before food, but the newer insulin like Fiasp need to be given maybe 5 minutes before food because they act very fast and if you give them half an hour, by the time you start your meal you are already hypoglycemic. So certain properties of insulin you need to know very well. So are there any novel routes of administration of insulin? Because people fear the injection, the pain and they are averse to taking insulin because of that. Are there other varieties of insulin available? Yes. Inhaled insulin has been developed, which I will discuss in a short while. Oral insulin also has been developed. However, the problem with oral insulin was it was getting degraded fast, acting after a long period of time, and therefore it was not actually having its desired effect. However, as recently as August 38, 2022, the University of British Columbia has presented a paper where two researchers have come very close to developing an oral insulin molecule in rats, show that it acts very rapidly and has a very good effect. And hopefully if we can get an oral insulin, our dream towards achieving a very natural way of taking medicines actually comes true very shortly. As coming to the inhaled insulin, which is available, there are two which were available. One is The older one, because of a lot of side effects, has been withdrawn, but the newer one, Afreeza, which is having technospheres of insulin, can be taken by an inhaler and then it is actually effective. However, the percentage of insulin which gets absorbed is less. Some may have lung-related problems, and then you need to monitor your lung function very frequently. What you see on the right is the device for taking this inhaled insulin. However, it is not a very practical way of doing it because of the kinetics which are very much involved. Based on the dosage which you use, you can give the units based on this inhaler. And next, coming to insulin pump. Insulin pumps are very well available now. You can put a pump, you can program the pump and then leave it so that based on your meal timings, it will give a bolus dose and otherwise keep giving you a basal dose so that you're mimicking or sort of mimicking the physiological insulin release in the body. However, the person using should be a little bit aware of how to use that, and then you should be always on the lookout for a pump failure or pump malfunction so that you don't get into hypoglycemic problems. So I won't go through this insulin because I've just discussed with it. We have short of time and then I want to conclude very fast. So this slide basically sums up the different categories of insulin, how they act, what is the onset of action, when it peaks, and what is the duration. And based on these characteristics, you decide what type of insulin is best for your patient. In a primary care setting, your regular human insulin is probably good enough for most of the patients because the newer insulin analogs being very costly, patients may not be able to afford it. It is important that patients take the drug rather than what drug they are using. A fancy drug may appear very good, but if it is not used at all because of the cost, it won't serve its purpose. So, based on your patient profile, the affordability, and what is his profession, age, risk factors of hypoglycemia, you need to be very wise in choosing what type of insulin you are going to give that patient. People say, why take insulin daily? Are we having or moving towards a weekly administration of insulin? This phase 2 trial involving iCodec, which is a once weekly insulin, is being done, and it has shown promising results. And maybe in the near future, you will have a once weekly insulin which we can use, and our patients will get a relief of pricking only once a week. This is what is involved in taking insulin. You have the pen, you need to fill it with cartridges, you need to apply the needle, and then the pens are very user friendly in terms of delivering the dose, and then you need to be aware of how a pen works. So it is a very good habit to show how to load a pen, demonstrate that first dose of insulin in front while the patient is there in your OPD so that he is quite comfortable and the phobia associated with insulin and the needle goes away. So when you spend about 30 to 45 minutes for the first time when a diabetic patient meets you and then clarifies his doubts, he becomes reassured and leads a normal life. Thank you so much for your patient attention.
Thank you, Srirang. That was really fast. Actually, this topic needs a whole day, but because short of time, we have to finish it off. Our next and the last speaker will be Dr. Srinivasulu, who will be talking about malignancy, cancer. Somebody from the managing side? I request Dr. Shamsundar to please join me on stage. This will be the last topic of the day. After that, we have the awards night. We are expecting the minister to be here in 15-20 minutes' time. So I request our professor to please be short and sweet.
Good evening, everybody. At the outset, I would like to thank the organizers for giving me this opportunity. The topic given to me is early detection of cancer, reality and myths. So as all of you know, burden of cancer is increasing in our country. The non-communicable diseases like diabetes, hypertension, and cancer, they are taking the center place. The cancer incidence is increasing due to increasing population and aging population because of increased life expectancy, increased tobacco consumption, and newer infections. Like 30% of the cancers are caused by viruses and bacteria, environmental pollution, and faulty dietary habits, and finally, it's a lifestyle disease. Like diabetes, hypertension, and cardiac disease, even cancer has become a lifestyle disease. The significance of early detection is, if you diagnose cancer in a first or second stage, then it is cured in more than 80% of the cases. When the diagnosis is made in third or fourth stage, the cure rate drops to less than 20%. Not only that, the treatment is less mutilating and economical in early stages, and the treatment burden is less. Maybe the patient can be cured with a single modality instead of multiple modalities. As you know, the carcinogenesis, it is genetic susceptibility and immunosuppression on one side, carcinogens acting on a cell to make it a cancer cell. Briefly, the carcinoma starts in a single cell, then it becomes non-invasive cancer, then an invasive cancer, and finally it's a metastatic cancer. When we look at the early detection, there are two methods. One is screening, that is looking at the asymptomatic population, and early diagnosis in symptomatic individuals. So this is the brief interval. The symptom onset, if you do screening before the onset of symptoms, we have got the general population screen and early diagnosis made. But once the symptoms are made, again, you can make early diagnosis and cure them better. What about screening? Examination of asymptomatic individuals for early detection of disease or its precursors is screening. But as far as cancers are concerned, very few cancers are amenable for screening in general population. The reasons are, in any screening, we have bias, what is called lead time bias. You can look at this. Without screening or with screening, the patient is going to die at the same age. But because you have screened and detected the cancer early, apparently the patient has lived for more time. This is what is called lead time bias. Comes to length time bias, the cancer is not one disease. In each organ, now we have molecular classifications where the cancers are of different virulence. We have got at one extreme, extremely benign cancers, other extreme, extremely virulent cancers. Like in breast cancer itself, we have got what is called luminal A, where excellent survival is there, and many patients live without treatment for long. Whereas in other extreme, we have got the triple negative breast cancer, which has got very virulent course. When you do screening, these less virulent cancers are diagnosed more. It gives apparent increase in the lifespan without there being any real benefit. Then we have got that overdiagnosis benefit. Sometimes many cancers are there in the body, they never manifest, and finally the patient dies of other causes. The classical example of that is prostatic cancer, where at the age of 90 years, more than 90% of the patients, if you do a serial biopsy of the prostate cancer would be there. We are overdiagnosing it. We'll come to that later. So you look at this, in a screen group, 3 cancers are diagnosed, only 1 died, that is 33% mortality, but natural death is at the same time. The unscreened group, only 1 patient is diagnosed, and that patient dies. Again, here you look at 100% mortality, but it is not true. You are unnecessarily detecting cancers which are never going to be apparent. So this is what is called overdiagnosis bias. Not only that, screening leads to overtreatment, anxiety for the patient, and also cost. Looking at all the aspects, what happens is we have got randomized clinical trials where we don't look at the reduction in mortality, it's overall. You compare 2 groups like 2 villages or 2 cities which have been randomizedly allotted to one screening or the non-screening. We look at the overall mortality from the cancer. Thereby, we come to a conclusion whether screening is useful for that particular cancer or not. Based on that, screening for general population is recommended only for 4 cancers. One is the cervical cancer. As we know, cervical cancer has got a definite etiology now, that is the HPV-induced cancer. It has got a long pre-cancerous stage in the form of different dysplasias for 10 years before it becomes invasive cancer, and gives us a great opportunity to diagnose the precursors and prevent onset of cancer and also cure it. And then the breast cancer, the oral cancer and the colorectal cancer. These are the only cancers where recommendations are there for general screening. So for cervical cancer, it is 21 to 29 years. Onset of screening at the age of 21. Pap test every 3 years. No HPV testing up to 21 years. And then 30 to 65 years, either do a co-testing every 5 years or only pap smear every 3 years. Thereby, we can detect precursors and treat them with good cure rates. In breast cancer screening, 20 to 39 years old, monthly breast self-examination, and 40 to 49 years, monthly breast self-examination, yearly clinical breast examination by a professional, and mammography every 2 years. Between 50 to 65 years, up to 69 in some recommendations, monthly breast self-examination, yearly physician examination, and yearly mammography is going to detect most of the cancers in early stage where we can cure with single modality. Then oral cancer, it is specific screening for Indian conditions. Here just a visual examination of the oral cavity and palpation of the oral cavity, where you can feel any thickening in the oral cavity, any ulceration in the oral cavity, leukoplakia, erythroplakia, they are diagnosed and the patient can go testing. The colorectal cancer is another cancer which is amenable for screening in Western countries. Even in Indian situation also, the colorectal cancers are increasing in incidence, and it is time we also have a regular screening program for this. The fecal occult blood test every year from 50 years onwards, a diagnostic colonoscopy at that age, then annual fecal occult blood testing, and every 5 years flexible sigmoidoscopy, and every 10 years colonoscopy will detect pre-malignant conditions like polyps. Again, colorectal cancer has got a long precursors like got adenoma carcinoma sequence. It takes 5 to 10 years. So by detecting these polyps before they turn malignant, we can cure most of them, will prevent cancer occurrence. So these are the only cancers amenable for regular screening. Comes to some other cancers, there are recommendations to screen the high-risk population. One is lung cancer, ovarian cancer, and the pancreatic cancer. The lung cancer screening criteria at 20 pack years, that is a person who smokes 1 pack of cigarette for every day for 20 years, we call 20 pack year. Those who have 20 pack year usage, who are current smokers or who have given up smoking less than 15 years ago, should have annual low dose computerized tomography of the chest annually from 50 years onwards to up to 80 years, and it has yielded results, and it is one of the current recommendations. So it is only for 20 pack year smokers. And then ovarian cancer, it is a cancer which is usually diagnosed late, but unfortunately in general population we do not have effective screening tools. But in a particular subset of individuals with strong family history, where 1 first-degree relative or 2 second-degree relatives have ovarian cancer, or those with BRCA mutations, they should undergo ultrasonography of abdomen, pelvis, and transvaginal scan, CA125, and clinical every 6 months to 1 year. And the screening should start 10 years before the onset of the index case. But the evidence is low quality. Next, pancreatic cancer. This is one cancer which is a silent killer. Most of the pancreatic cancers are detected very late, and most of them are incurable. In these, certain conditions like family history and another interesting recent onset of diabetes and BRCA mutations, they are screened annually with endoscopic ultrasound, MRI, and screening should be started 10 years before the index case, and it is also has got a low quality evidence. Interesting thing is some screenings were recommended and then abandoned. This is because of, again, we talked about the bias, detecting unnecessarily cancers which are never going to manifest. The classical example is prostate cancer. Once there is a lot of stress on PSA examination, but now that is given up. What is recommended is a physician should never recommend PSA testing for any patient, any individual. It is not a screening test. But the individual wants to get it done, you can recommend it, but we are not going to tell them get PSA done as a screening. Another interesting is the thyroid cancer. This has happened in South Korea. They had a screening program. Once the screening program started, they are detecting more and more thyroid cancers, papillary cancers, which are less than 1 centimeter. And then the surgery rate has gone up by 80%. 8 times surgeries they are doing. And suddenly they realized that they are unnecessarily doing surgeries on cancers which are never going to get manifested. So they given up the screening program. In India, the government program includes the 5 diseases are getting screened. One is diabetes, other is hypertension, and 3 cancers, cervix, breast, and oral. The cervical cancer is by visual inspection and visual inspection after acetic acid painting. Then breast is done with palpation by a health professional and oral by inspection by a health professional. This is very cost effective. It is not going to detect precursors, but it is going to help our population. Something is better than nothing. When it comes to the early detection, it is by early diagnosis. The early diagnosis is by heeding to the early warning signals of possible cancer. You got this? Be cautious. Bleeding or discharge that is unusual, extraordinary loss of weight, cough or hoarseness that persists for more than 3 weeks, a sore that does not heal, unusual change in bowel habits, thickening or lump in breast or elsewhere, indigestion that persists, obvious change in a water mole, unexplained loss of appetite, and some difficulty in swallowing. This mnemonic, be cautious, should be remembered. Most of the times, the symptoms should resolve within 3 weeks. The symptoms persist for more than 3 weeks. We have to investigate what is the reason for the symptom and then make a diagnosis. It need not be due to cancer, but investigation and diagnosis becomes important. So these are the problems we face. The first symptom, there is access delay. The patient who is having the symptoms, they take time to come to the physician. But more important from our point of view is the poor performance and referral issues. Many times the physicians, they don't diagnose that it is due to cancer. The classical example is rectal cancer, where the classical saying is, if you don't put in a finger in the rectum, we'll put our foot into that. So most of the times the bleeding rectum is treated as piles until the patient develops advanced symptoms. Many times it happens that the patient is attending physicians, but awareness of the physician also is very important. Once the diagnosis is made, then we have issues of waiting lists, suboptimal resources, all those things. And there are financial barriers from the patient point of view, logistical barriers, and because there is a lot of distance between the patient's native place and the treatment center, psychosocial barriers. People don't want to get diagnosed with cancer, so they avoid coming to the hospital. So all of these are creating problem in early diagnosis. The best would be in cancer primary prevention. 50 to 60% of the cancers are preventable. As we said, the cancer is a lifestyle disease. These are the main causes. We know tobacco, alcohol, viruses. Cervical cancer is due to virus. And then hepatitis B, HCV, and liver cancer association. And diet is very important, esophageal and gastric cancer as well as colorectal cancers. And other things are less important. So the primary prevention is by a cancer-free lifestyle. Avoid tobacco, moderate alcohol intake. Now the recommendation is changed to no alcohol intake. Balanced diet, like carbohydrates, fats, and proteins in proper mix. Safe sex to avoid the sexual transmission of viruses. HPV is sexually transmitted. HIV is sexually transmitted. Vaccinations against the infectious agents causing the cancer like HPV vaccine for both cervical cancer and penile cancer, and hepatitis B vaccination, etc. Physical exercise, mental relaxation, avoid unnecessary exposure to chemicals, drugs, and radiation pollutants. That will lead to a reduction of 50 to 60% onset of cancer itself. Fresh fruits and vegetables containing vitamins, avoid salted, smoked, fried, fast, high-fat, spicy foods. All the current food fats, they should be avoided. And then there is surgical prevention. If you see some conditions which are likely to end up in cancer, do surgery and treat them. Chemo prevention under investigation, nothing is proven except the tamoxifen in breast cancer. So to conclude, 25 to 30% of the cancers are amenable for screening. Most cancers can be diagnosed in early stages if early warning symptoms are adhered to both by the patient as well as by the physician. But 50 to 60% of cancers are lifestyle related and are preventable, and our stress should be on that. Thank you.
Thank you, Dr. Srinivasalu. I think this is the end of our clinical symposium. Now we are awaiting the arrival of our minister so that we can start the awards night. It will be just 5 to 8 minutes in time. I request Dr. Srinivasalu to please accept some memories for the conference.
Thank you so much, sir, for your valuable time.
This is something very different from me. Normally, we have our CMEs, we start in the morning, end up in the evening, and that too organized by our medical associations or our particular subject-wise chapters. This is something new which I have done in my life. Every day something new comes up, something new we learn. Getting a symposium organized for a non-medical thing is something different, but all said and done, I appreciate all the doctors who have come over here and given their patient listening, especially the young ones who are going to come up in their life tomorrow, and maybe they are going to face things like this in life before. I thank the management of Hybiztv and the management in general, because every day this person, Sai, who is standing here right to me, he was sitting in my clinic waiting for me to finish my OP, then come in, sit for half an hour and tell me this is what is happening, this is what I want. So these are some tedious things, but all the groundwork basically was done by the Hybiz group, including Sandhya madam. I don't think she's here. She might be busy receiving. It was a great experience for me. And I thank everybody from Malaradi College to our doctors to the people who have given us this area, the HICC people, for doing such a great arrangement. And we hope we'll have many things in future coming up like this. Awards will come to many people, will go, but that is not a temporary thing. Every year this thing will come, and every year we'll be trying to receive something better. Thank you, great audience. Thank you for the time, and we hope to start our next program soon. Thank you very much.
Well, thank you so much, Dr. Sanjeev Singh ji. आप भी रहिए stage पे, please. Request you to be here. Thanks for accepting our invitation and moderating this entire session so well. As you have mentioned Mr. Sai's name and Vijesh from the Hybiz family, would like to thank you for your valuable time and, of course, being the moderator for the session. Ladies and gentlemen, you've been patient enough to be all through the session. Thank you so much, sir. Thank you. So, ladies and gentlemen, as Dr. Sanjeev has already mentioned that we are eagerly waiting for the award function to begin. But we will break for 5 to 10 minutes. We are waiting for Harish Rao Garu to join us soon. Until then, sit back, relax, enjoy the ambience, and we'll see you at the other side of this break with